Hi, Dr. John Bennett. How are you today? Can you see me and hear me?
Yes,
Yes. How are you doing? How are you doing today?
good, good. You can hear me. You can't see me, obviously. You start in half hour, right? When do you
Y-
start?
Yeah, exactly. How in a half hour?
Okay, I'll be back.
Sure, great.
Uh, Good luck.
Good luck. Waiting for you. Just hop in whenever you like. So I guess we got one viewer over here right now. So okay, welcome to the show. We'll be starting in about half an hour from now. Hello everyone. The webinar will be starting in about 27 minutes from now. So please feel free to stay in the Zoom room. And if you have got any, anything to talk about and any comments or suggestions, please feel free to use the chat box, the chat function, and we will be starting shortly. I hope you all have read the papers I have sent to you. So please if you wish to discuss anything if you want to ask any question, basically to to our speaker, feel free to share it now or during the webinar. Just try to wait for about 36 minutes and we will be starting as soon as Professor Duffau joins in. Thank you. Hello and welcome everyone who is present right now. Hello and welcome to everyone who's present right now. We will be starting shortly in about 19 minutes from now. So please feel free to use the chat box and share where are you from. I will be so happy to know where are you watching this webinar from. And please feel free to use the chat box during the webinar to share your comments and your questions so that we can discuss it during the meeting. So actually we will be starting in about 19 minutes from now, and it's so good to see you all here. Please feel free to share your questions and your comments in the chat box, and I will also share the winners of the yesterday's lotto sort of a thing that we held yesterday. I will be giving out my book of robotic neurosurgery to three of the winners. So I will be announcing the winners soon today in my WhatsApp group. If you are on my WhatsApp group, please stay tuned if you've been online yesterday. And I hope you will like today's lecture. It's a very, very important topic to be discussed, and I think you will be finding it very interesting and insightful as well. I'm hoping there will be lots of questions also in your mind, so please feel free to share it in the chat box. And so just write me where are you watching this webinar from, and I will be so happy to know you and to say hi to you. Okay, hi, Asma. That's great to know. Malaysia is a beautiful country. I've been there, and I've attended, a development symposium in Kuala Lumpur in I think it was in 2018. Yeah, it was a very wonderful place to visit and a nice place to look at. And I can see my friend Dong Yan, Trung Yan Dong. How are you doing today? It's so good to see you here. You're a wonderful neurosurgeon, very active and passionate about neurosurgery. So it's good to see you here. I guess I can see so many familiar faces, and we will starting in about 70 minutes from now. So, in the meantime, just try to share where are you from, and if there is any specific topic you want me to arrange a webinar on, please feel free to share. Can you hear me, all of you? Please let me know if you can. Also, I'll be going through it. Starting in about 70 minutes from now. So, in the meantime, just I can see you can hear that. Is anyone else in the list who cannot hear me? Please let me know. Is there anyone who cannot hear me? Please let me know if there is any problem in the audio. I will go through it and let you and we'll fix it. Hello there. It's so good to see you all today in the Zoom room, and it's so good to welcome you all. Please feel free to share where are you watching this webinar from, and like all of my previous webinars, I will be sharing a link to a quiz after this webinar. You will just have to submit that quiz, and you will receive your own personalized copy of the new certificate in your email inbox. So I'm sharing the link of my WhatsApp group again. Thank you very much, Dr. Kian. I hope you are doing well and doing wonderful in your country. I've seen you are doing a lot of good things and very passionate about neurosurgery. So this is the link to my WhatsApp group. Please feel free to join it so that we can all stay updated. I usually share all the updates here in this group. My next webinar so far will be held on 27th of April with Professor Faris Shaddad Neto. So please stay tuned. There are a few other webinars that we are planning and are in the pipeline. So just I will be sharing and updating you about those very soon. Please feel free to share your questions and your comments in the chat box so that we can take during the discussion session. It will be so. I hope it will be of your great interest to discuss all these things. if there's any specific topic you wish me to organize webinar on, please feel free to share it with me, and I will be so happy to arrange a webinar on that particular topic, if that's possible. And as you know, my new book with Professor Luis Borba will be hitting the shelves so soon. It's on basic, coronavirus, so you will be having a chance of grabbing this very quite soon. Oh, we will be starting in about 14 minutes. So stay tuned. I hope you all know about the news initiatives and my website as well. So, have you all checked it? There are a lot of initiatives on my website for you to have a look at. It is, I'm showing this in the chat box. Please to go through this website and see all those initiatives that are in my mind I'm working on, and I hope that that will be of your interest. And I'm starting a very new project that will be very exciting for all of you, as it is much exciting for me as well to plan it, because I want more participation from young neurosurgeons from all around the world. So I think that initiative will be very, very, interesting and very, very exciting for all of us equally. So I will be sharing more about it on my website soon. I have a free journal. I'm going to work more on it, and I think that will add more value to all these things that we are doing all around the world. So let's stay tuned, and we'll be starting in 13 minutes from now. Professor Duffau is here. Hello, sir. Bonjour. Hello, sir. Hello, sir. Can you hear me? Hello, Professor Duffau. So good to see you and welcome you here today.
Uh, can you hear me?
Yes, sir. Thank you so much, sir. So good to see you.
Thank you so much. Thank you for your invitation. I hope you will enjoy the talk and the discussion.
Thank you very, very much, sir. We are so excited, and I would say it's a huge privilege. So, in French, I think I know a little French, but I don't know how my pronunciation is. But it's une honneur et privilège pour moi to have you here today with us. So it's a huge, huge privilege for me and for everyone who is right now in the room. People are joining in. So, thank you very, very much for spending time on from your very busy schedule.
Thank you so much. It's my privilege.
Thank you, sir. It's so kind of you. It's a lot of generosity, sir. It means a lot to us because we've always been quoting your papers. We will be citing your papers. Are discussing all your theories that you share, all your research whenever we are talking about low grade gliomas and everything. And I remember that I've been in a local conference a few days ago, and we've been discussing about you, how you deal with the low grade gliomas and everything, and it was like a dream come true for all of us to have this privilege of listening to you today for the news webinar series. So again, thank you so, so much, sir. Sir, we do have 10 minutes, but as you know, that this webinar is also been broadcasted on my YouTube channel as well as on neurosurgical.tv. So there are so many viewers on all those platforms as well. Sir, would you like to start it right now? Because I hope that viewers will keep on jumping in during the webinar as well. So if you like, we can start now if you say.
It's okay. I will first of all try to share my slides in order for you to be sure that you can see them.
Yes, sir, we can see them. You can just, if you like, you can check the slide share function. Yes, sir. Perfect so far. So far, so perfect.
Perfect. So definitely I can start, but I can wait for 5 minutes more if you want. You decide. You're the boss today.
No, sir. Actually, I believe that many people will keep on, joining during the show. So, sir, I know you have a very busy schedule. So sometimes when wonderful teachers like you come here, it's like we feel so much grateful, and we know that it would be good if you start if you like to start it early, because we don't want to keep you waiting for so long, because viewers just keep on jumping in during the show.
Okay, perfect. So I will start. And first of all, I would like to thank you very much for giving me this unique opportunity to share my experience. Now, as you can see, 26 years of experience, specifically dedicated to the field of low-grade glioma and, as you know, wake surgery. My goal being, since the beginning, to try to make some links between the neuroscience and neuro-oncology and surgery, of course, within the brain. And to start really to explain my philosophy, I would like to insist on the fact that diffuse gliomas are, in essence, not well delineated. Everyone knows that, but in meetings, it's very frequent for me to have to answer this question where you stop in the end. And in fact, my goal is not to try to remove a tumor mass because it does not exist, but to try to remove a part of the central nervous system according to the functional boundaries at the individual level by taking a margin around what we cannot see on MRI, or sometimes by removing the tumor, but also by stopping a little bit earlier because of critical networks. In other words, to find the good balance between the functional issues, preservation of quality of life, and to remove as much as we can, and sometimes to do a supratotal resection, because definitely what we are seeing on the MRI is not the disease. So if we do the resection according to functional boundaries, we have to better understand the brain. And my second goal was in the field of neuroscience to break with the concept of localizationism. And you can see that we started to do it more than 20 years ago, because very quickly I understood that there were no specific areas corresponding to specific functions, explaining why the patient with low-grade glioma, so a slow-growing disease, can enjoy perfect normal life before and after surgery. And more, we try to model what should be the better understanding of neuroscience because before to go to the operating theater, namely in low-grade glioma, to understand that this tumor grew for many years before it used first symptoms, in the majority of cases, seizures. And then in the meantime, many reorganizations mechanisms occurred with modification, reconfiguration of the networks within and across networks. And more, you will understand when you will go to the war for this patient at that time, how these mechanisms occurred and allowed the compensation of the tumor growth for many years without any symptoms, more you will anticipate not only what you will do during the resection according to functional boundaries in this patient at that time, but also to anticipate what will happen after surgery and the possibility or not to reoperate, to reoperate, maybe to use chemotherapy in order to induce a shrinkage, and then to give the possibility to operate a fourth time, and so on and so on. And suddenly, we can change radically the natural story of the disease by playing with these mechanisms of neuroplasticity, because definitely localizationism does not exist, and we have to better understand the dynamics of the neural networks already pushed by the tumor growth and that we will use in order to do extensive lobectomy, as in this example, including within so-called eloquent areas like Broca's area, Wernicke's area, nonetheless in patients returning to a normal life. And this is the reason why, as I said in introduction, since the beginning, I tried to be not only a neurosurgeon, but also a neuroscientist by proposing new model of cognition, of functional anatomy, of dynamics of the connectome, and to publish them as a neurosurgeon in Nature, for instance, or Science, or Brain, and so on, not against the possibility to continue to perform surgery per se, of course, by yourself, and to increase this link between your possibility to better model the interactions within and across network, also to use these new models in order to increase both the survival of this patient. And you will see that now in my experience, my patients are living more than 20 years. I speak about median survival, which is the first time in the whole literature, and preservation of the quality of life with less than 1% of severe permanent deficit. Of course, the zero does not exist, but it's so exceptional. And to achieve this goal, so we started 26 years ago to change the paradigm by telling, first of all, we have to do early surgery in low-grade glioma. For you younger people, I hope that today this is just full of common sense. But you can believe me, 25 years ago, it was not, because the goal was wait and see. And we said, no, we have to treat it before malignant transformation, including in incidental low-grade glioma. For instance, we speak about that, an MRI performed because patient had headaches not related to the tumor. Second, to do this maximal resection, so according to functional boundaries, meaning that if you can take a margin beyond the flare abnormality, you have to do it because, of course, there are tumoral cells beyond what we can see on the preoperative imaging. I insisted about that initially because this is critical to understand the philosophy. And third, not the least, but not the less, the most important is really to preserve the quality of life of patients and then to know where to stop so to better understand the connectome in this patient at the individual level in this period of his life, knowing that if we discovered the tumor 2 years before or 2 years later, then the surgery would have been different despite the same location and the same patient. So I will not insist now on the fact that, of course, low-grade glioma are never stable. You have to do volumetric assessment systematically. It's not expensive. It would take just 2 minutes in front of the patient in consultation. And in all cases, you will demonstrate that this tumor is growing, sometimes very slowly. Of course, this is the goal, to avoid malignant transformation. Otherwise, if left untreated, all low-grade glioma in 100% cases will finish to become malignant. And of course, will induce decline of the quality of life and the patient. We have nonetheless to be more subtle today. And if a patient is in front of you with the diagnosis of low-grade glioma, with the first MRI because of the first seizure, and if the patient is telling you, I enjoy my life, so it's crazy for me to understand that I have a so big tumor because I feel so well. Please save time in order to do neuropsychological examination objectively before and after each treatment, but especially at diagnosis. And probably you will be so surprised, and your patients too, because as you can see, in more than 50% of cases, even if the patient thinks that he enjoyed a normal life, in fact, it's not totally true. They have already some degrees of cognitive deficit or emotional deficit or behavioral deficit. And this is very important to understand, because this is one way in order to know if the limitation of neuroplasticity was already reached, and then plan your surgical strategy, maybe to do reoperations, and not only to take into account the location of the tumor per se, but also the relationships between the tumor and the connectome when we made the diagnosis, once again, many years after the beginning of the tumor, which is, as you know, unfortunately, of course, unknown today. Then you can tell me, yes, but if they exhibited some degrees of mild but objective cognitive deficit, that means that finally there are some limitation of neuroplasticity, but that localizationism exists because it's related to the location of the tumor. And my answer will be no. Deficit is not related to the lobar localization of the tumor, but the invasion by this diffuse disease of the white matter tracts, the limitation of neuroplasticity by the tumoral cells, because this is not a tumor mass, but a migration along the connectivity. Typically, if you have already some invasion of the inferior frontooccipital fasciculus, for instance, before any treatment, at diagnosis, then you increase very significantly the risk to objectivate the existence already of some degrees of semantic disorders before any treatment. And everything then is clear for you when you go to the operating theater, because you know that you have to be specifically more careful about semantic processing in this patient at that time, in my example. Speaking about oncological considerations, of course, you know, thanks to the works performed by Bischberger, initially in San Francisco, but also in France, not only in Montpellier, but the glioma network, that about 1,500 low-grade gliomas, if the tumor is bigger before and after surgery, then the risk of malignant transformation is higher, so the median survival is reduced. This is the reason why no wait and see. We have to treat as soon as possible. But what we introduced in France is this concept of growth rate. It's very easy to calculate. You do a MRI, a second MRI before to operate. And you calculate objectively the 3D volumetric assessment, because this is a tumor, so it cannot be considered just by using diameter. And then you will see if 1 to 3 months, not waiting for many years to operate as soon as possible, there was already some modification of the volume. And in the vast majority of cases, the answer will be yes. And of course, more the tumor is growing, worse is the prognosis, which is full of common sense. All patients can understand that. And nonetheless, the growth rate is not yet incorporated 20 years later in the guidelines in oncology. Why? This is totally against common sense. You can tell me, yes, but in fact it's a bias because it's directly correlated to the molecular pattern. No, we demonstrated that you can have very rapid growth rate before any treatment in oligodendroglioma, and at the reverse to have very slow growth rate in IDH wild type. Of course, maybe statistically you will increase a little bit the risk to see higher growth rate, rapid growth rate in wild type. But at the individual level, it does not work. So we cannot conclude only on the basis of molecular pattern, which is just a part of the story. And to demonstrate that, I published a few years ago my series regarding the wild type gliomas, and you can see that after 8 years, we had still 84% of patients still alive with wild type. So you cannot say, we have a wild type tumor, we have to do a STUB because the prognosis is not good. At the individual level, that means Nothing. When I started, so 5 years ago, the median survival low-grade glioma considered nonetheless benign at the time, wait and see, was 6 years. So you imagine that, of course, it's a very aggressive concept. Then we increased the median survival around 15 years, more or less, at the level of the low-grade glioma network in France. And it was already 5 to 10 years ago. By doing more extensive and earlier resection. And you will see a new results now over 20 years, as I said during the introduction, which is unique in the literature. And before to show you these results, I would like to explain how I did in practice, and definitely to remove a part of the brain according to the individual functional anatomy at that time. We have not the same brain. Localizationism does not exist. Between the first and second surgery, if you can reoperate the patient, the map will change over years in the same patient. Everything is dynamic. So we have to deal with this very positive information when we have tumors located within so-called eloquent areas, because I spent my life to remove tumors located within Broca's, Wernicke's, the central area, and so on, not selected by very good neurosurgeons elsewhere in France, in Europe, and on the 5 continents, just based on the dogma, the thought that if they removed this tumor in this location, then the patient would have permanent deficit because the dogma of localizationism, which does not exist. Otherwise, about more than 1,000 patients in my experience, you can imagine that the vast majority would have experienced permanent sequelae, permanent aphasia, hemiplegia, cognitive disorders, and so on. And the answer is no. Why? Because the brain is dynamic. And I have tried to understand what happened before my surgery, because the brain was reorganized according to the tumor growth for many years until the diagnosis, and then to use this knowledge into the operating theater and to propose new model of cognition based on these dynamics between and within networks. I will systematically continue to insist about that throughout this talk, because this is the secret to change radically the results. So, of course, we have fMRI now. I know I made a PhD in fMRI 20 years ago, but this is the reason why I know very well the limitation of this methodology, which is absolutely fantastic for research and as a didactic tool. But at the individual level, it's dangerous. Dangerous. Why? Because fMRI today cannot give you the critical areas versus the areas you can surgically remove, finally with a complete recovery. And I spent once again my life to operate patients not selected for surgery by other neurosurgeons everywhere in the world, because the fMRI said, be careful, the activation is very too close to the tumor. And my answer was, yes, but if the cognitive assessment is perfect before surgery, that means that this area, in essence, is not critical for language cognition while you want. Otherwise, you would have already experienced some degrees of cognitive deficit. And the cognitive assessment is normal. So that means that your brain compensated. Yes, but there is an activation. I do not care. This is not the truth. Just biomathematics. Same thing regarding the everyone knows principle. I mean, movement of water molecule. We have understood. Okay, so if we have understood, do not say that this is the function. This is just an approximation of the structure. So it does not mean that you cannot cut a part of some termination of the fibers, for instance, running to a cortex already reorganized. In addition to, you have absolutely to know these papers, not by Montpellier, but by the expert in the world, published only a few years ago, who selected one data set, asked to so many centers to build their, according to their methodology, just a very typical pathways and easy pathway like the arcuate fasciculus and the cortical spinal fasciculus in this example. And you know what? Never they found the same results with the same data set. So that means that this methodology cannot give you any functional information intrinsically. And second, the expert today disagree regarding the methodology to use in order to build the pathways. How do you want to operate with that? With 99% of reliability? And the answer is you cannot. So technology is not adapted to this kind of surgery. So please awake the patient. In order to wake the patient, in order to benefit from cognitive monitoring throughout the revision in real time. What wants the patient is to live longer. Okay, you have to remove more, but also better. Okay, you have to preserve the function. So please ask to the patient to do movement language during your stimulation cortically and at the level of the white matter tract throughout the revision, because white matter tracts are the limitation of neuroplasticity. I will insist about that in a few slides. In other words, you need to have a neuropsychologist and or speech therapist into the operating theater, and they are not expensive. You do not need intraoperative MRI, neuronavigation, fMRI, DTI, electrocorticography, microscope, and so on. You need nothing, just a fork and a knife, but your knowledge of the functional anatomy, because we should be neuroscientists first. And dynamics within your own team, interactions between the anesthesiologist, the speech therapist, and your psychologist, and so on. And if you do that every day, a week at least, with the patient in the center of your operating theater, then we can really select the best intraoperative task, not only for the patient to avoid to be aphasic and hemiplegic, but also to return to normal life according to the job, to the lifestyle, the hobby, habits, and so on. But also according to the environment, because as you will see, I received many patients from many countries, in fact, 34 countries from the 5 continents. So we have to adapt to the language, but also to the legal issues. I mean, in France, if you have hemianopia, you cannot drive. So you have a risk to lose your job. To be honest, in Pakistan, I don't know. But in North Africa, you can drive. So you see that the consequence will not be the same according to the wishes of the patient and his environment. For instance, in US, the first country in the world, you are not reimbursed when you need to benefit from postoperative cognitive rehabilitation, while in France, it's free. So all our patients will benefit from this rehabilitation after surgery. And then, of course, it will increase the rate of patients returning to an active life. Definitely, you have to stop according to the connectivity in the depth. If you cut the projection fibers, you will induce especially hemiplegia at the level of corticospinal tract. If you cut the arcuate fasciculus, you will induce aphasia, conduction aphasia, and so on. So the philosophy is not to remove a tumor. Duffau, can you feel the tumor in the depth to stop? I do not care, as I say. You have tumor on science for beyond what we can feel, what you can see on the MRI. You have to continue according to the connectivity and limitation of neuroplasticity, connectome-based surgery at the individual level. And the reliability is 99%. Never fMRI, DTI technology, what you want, will give you this level of reliability. And remember, more than 20 years of median survival. So if I can do it in Montpellier, this is the strong message. You can do it everywhere in the world. You do not need billions of dollars or euros. You can do it for free just with a succeor, aspirator, and a good team. To give you an example, before to continue and to show you results, you can see as a medical doctor, young, with incidental discovery because of headaches of this very big tumor involving the so-called Broca's area and without any troubles because the neuropsychological examination was normal before surgery. And what told me, of course, this young medical doctor, Jeffrey Zenon, is I would like to continue to enjoy a perfect normal life and to be a very good medical doctor after your surgery. And not just I do not want to die or to avoid to be hemiplegic. So you see, the level of expectation is totally different. And I can understand that because they are living 20 years. So if you had a low-grade glioma, if you had the possibility to live more or less one generation, 20 years, and to make long-term project, you would like to continue to do exactly the same thing and not just, oh, the patient is not hemiplegic, I am very good. And no. So to understand that, we have to do cognitive assessment through characterization. And I have a habit, so to do a positive cortical mapping, in this case by showing where is Broca's area, which does not exist because 1, 2, 3 is in fact at the level of the ventral premotor cortex, namely the left part of the precentral gyrus. No, so not the inferior frontal gyrus. And the patient is doing, as you will see, many tasks simultaneously, moving, understanding, naming, and so on. And finally, there was one area inducing language disorders beyond the speech arrest 1, 2, 3, namely at the level of the dorsolateral prefrontal cortex, which is 5, and which is not the so-called Broca's area because now I'm removing the inferior frontal gyrus in the left so-called dominant hemisphere in the medical doctor, but the posterior and upper part of the resection, namely the junction between the ventral semantic pathway and the dorsal phonological pathway. And you have to see that in your mental imagery. Otherwise, you cannot pray the brain to see the connectivity without DTI. According to that, of course, now it's very easy for me and then for you to do just a subial dissection. You will see that I coagulated the cortical surface because I know that it's a true negative mapping because I had a positive mapping, especially at the level of the 5 dorsolateral prefrontal cortex. And then I can remove very quickly the inferior frontal gyrus by avoiding, of course, to split the sylvian fissure. It's good if you have an aneurysm, but the goal here is to be within the brain. So do not split the subside. And then you will never, never, never be into the contact of the vessels. Then you will never, never, never have any stroke. So if you adapt your resection according to the cortical functional boundaries and in the depth, of course, the white matter tracks of the limitation of your plasticity, if you do not coagulate in the depth, if you are never into the contact of the vessels, no spasm, if you have never stroke, you have 99% of the results. It's finally full of common sense and so very easy. And you can do this kind of resection very quickly. Oh, we have wake surgery today. It will be a nightmare because we need 8 hours to remove that. I start every day at 8, at noon is finished. Even for this big tumor, because you see, no bleeding, no coagulation, very quick resection, subial dissection. And this is true also within the insula. Now I will put a retractor in order to enter within the insula and do a subial dissection. And of course, what is the danger in the depth? The inferior frontooccipital fasciculus running in the temporal stem I simulated, and I heard from my speech therapist, semantic paraphasia. Okay, I understood. I have to stop. Yes, but maybe before there is a residue in the depth. And so what? I will not cut the ventral semantic pathway. This guy is a medical doctor. He told me before surgery, I want to return to normal life. So you have to preserve the ventral semantic pathway. And it's exactly what I did. This is the post-operative resection through Broca's area, which does not exist, and with a small but objective residue at the level of the anterior perforating substance, because what I want for my patients is to return to normal life. And that works. Yes, but you left a small part of the tumor Duffau. Yes, but in normal life. Yes, but your median survival are shorter. No, they are longer. Because if you live normally, you will live longer. And because I will come back according to the mechanism of neuroplasticity. So you have to anticipate ahead, at least 5 to 10, maybe to 15 years in advance ahead. The vast majority of neurosurgeons I know everywhere in the world today, they will tell me, okay, we have understood the Broca's area does not exist. We have to do wake surgery in the left so-called dominant hemisphere, but not in the right non-dominant hemisphere. Oh, really? You think that I do not need to do talks to have my ideas for 25 years or to do wake surgery in today's, in my operating theater, I do not need my right hemisphere. I need just the left. I need my brain, both interactions. So the right so-called non-dominant hemisphere, according to the classical dogma, and especially the localizationist view, blah, blah, is critical for complex movement. If you are a surgeon, you need, of course, every day, not to be hemiplegic, but also to have a very high level bimanual coordination. So you need something more. It's critical for spatial cognition if you want to drive. It's critical for social cognition if you want to continue to talk with your colleagues, with nurses, and so on. It's critical for non-verbal semantics. You do not need language to understand. If you cannot understand symbols, you will die. Animals understood that. They are not speaking to the world by language, and nonetheless, they have semantics. Executive functions, exactly what you try to do. So many informations. But I never say that we have to work a lot. We have to change everything. And suddenly your patients will live longer and better. You need your right hemisphere to do it. And the emotion. I am myself, my personality. I cannot change. I do not want to change. If you reset my right non-dominant hemisphere, I will change my emotional processing. And human beings is first of all emotion. So we have to be objective not only before, but also after surgery by doing systematically cognitive assessment. And not just my patient is not hemiplegic. Okay, it was good in a meeting of their surgery 30 years ago. Now, what we would like for the patient to enjoy normal life, including to return to work, which is true in our experience in 95% of cases, which is unique in the world. I do not understand why. It should be the standard. Because we have understood that despite the fact that I know the brain, blah, blah, in fact, I continue to induce some degrees of cognitive deficit, especially for the higher executive control functions, explaining why many patients can work but are tired. They have an increase of reaction time. They have to focus more in comparison with before. So in order to try to monitor, and not only to map, to monitor these higher cognitive functions into the operating theater, we developed the concept of multitasking, which is in fact an evidence. I'm moving, speaking, and try to explain to you using language, but also action. I do many things simultaneously. So how do you want to the patient to say, just please move, or please name, or please stop, stop. This is not a real life. So you have to ask to the patient to do many things simultaneously, moving, understanding, combining, self-evaluating, naming, and everything in 4 to 5 seconds without any rest. And every 4 to 5 seconds, the diaporama will change, the slides on your computer will change. So you will monitor sustained attention in 1 to 2 hours, because after that, patient will be too tired. So you have to operate very quickly without coagulating, subpyelization, you have understood. So when people are telling we cannot mimic the real life into the operating theater, they understood nothing. Of course we can. This is the reason why 95% of our patients are able to resume an active life, including to work. When people are telling, oh, it's too long, no, they understood nothing. It's because they are doing serial tasks to the patient rather than to combine tasks. And of course, we have to increase the motivation of the patient. That this is exactly what we are doing, to say to the patient when they come to Montpellier, you have to help me and I will help you. And suddenly, everything is easier. Not easy, but easier. First of all, Broca's area does not exist. You have understood? No. You have to include that, definitely, because it's true in Montpellier, in France, it's true, as you can see, in Canada, it's true in USA, it's true in China, it's true everywhere. So change this mind of localizationism. And now adapt the tasks according to the wishes of the patient by combining tasks, for instance, judgment if you are a lawyer, calculation if you are a mathematician, spatial cognition if you are a dancer, including in the so-called right non-dominant hemisphere. If this dancer is not able to dance anymore after surgery, even if not hemiplegic or aphasic, she will lose everything. But the classical neurosurgeon doesn't care, because he will think that this area is not critical for the function. What function? Working memory, we spoke about that. Syntactical processing for a writer, for instance, and so on. And in all cases, emotion. Surgeons, medical doctors, because I did so many surgeries in more than 100 medical doctors in my life, maybe a bias of recruitment. The first question is, as I told you, I would like to continue to be a medical doctor and a good medical doctor. So you should be empathic. And the empathy is not Broca's area, is not the left dominant hemisphere. It's interactions between networks, including the right so-called non-dominant hemisphere. So of course, we have to wake this patient in order to map the higher mentality, the possibility to perceive the emotion of people in front of you. So without that, without theory of mind, you cannot be empathic. So you will not be a good medical doctor. What means non-dominant? To build this mental imagery in your own brain, this is the goal for me to deliver this message today, in order to avoid for you to waste so many years. Then we need, of course, to make the link between the structure, and the best way is to do dissection of cadaver using the Klinger methods, in order not only to see the surface, okay, we have understood, but the fibers. Of course, you can use tractography, not into the ore, but as a didactic tool, as a research tool, before and after surgery. And into the operating theater, you can make the link with the neurophysiology, cortical and subcortical stimulation, and the cognitive monitoring. Okay, and now we start really to understand how the brain is processing. First of all, that if you cut the cortical spinal pathway, of course, you will be hemiplegic at the level of the corona radiata or the internal capsule. Okay, but once again, it's not enough in order to be a surgeon or a pianist. So there is another network involved in the control of complex movement, especially bimanual coordination, in front of the classical primary motor cortex, not only at the level of the cortical areas, but also the level of the white matter tract, the frontostriatal tract. When you stimulate it, if the patient was doing bimanual coordination into the operating theater and speaking, then you will block everything because this is a network involved in complex action and not just as now. It's very important because according to this frontostriatal tract and also the frontal ascending tract running from the supplementary motor area to the ventral premotor cortex, then you can induce the transitory SMA, supplementary motor area syndrome, or not. We said yes, but even if it's impressive with akinesia and mutism after surgery, they recover. I know that. I wrote that 20 years ago. But it's not totally true because they will recover according to the classical way of neurosurgeons. I mean, the patient is not aphasic hemiplegic anymore. Okay. But the patients are not totally recovering, speaking about complex action. Maybe it's not critical for the patient. Maybe the patient now is 65, not a pianist, not a sportsman, and telling you what I want is for you to remove more tumor for me in order to see my grandchild growing. Perfect. I will induce SMA syndrome. I know what it is. I described that 20 years ago. But if the patient is telling you, I am 35, I am a surgeon, I want to continue to enjoy perfect normal life, otherwise, no interest to continue to live, then you should avoid the supplementary motor area syndrome. Then you will not go until you will encounter the corticospinal pathway, but the frontostriatal pathway located in front of the pyramidal pathway. And the patient will totally recover. Yes, Duffau, but you will leave tumor. I will come back. The brain will change in the meantime. We will induce modification of the plasticity, reconfiguration. And 5 years later, I will remove this part of the tumor. And the patient will not have SMA syndrome. He will totally recover. And finally, he will live longer. And in the meantime, he will enjoy a perfect normal life. Dynamics of the networks over years and now over decades. And not just, I have to remove the tumor mass now, and that's it. And after that, radiochemotherapy, and it's finished. Oh, yes, it's finished. With less than 10 years of survival. This is true for the right non-dominant parietal lobe. Oh, no interest, no interest. The patient is not hemiplegic. But if you like sport, you need to have the sensory feedback and you need to have the awareness of your own body. Otherwise, how do you want to run, jump, and so on? Oh, it's not mandatory to do sport when you have a brain tumor before. You have not to judge. I have not to decide. We have to ask to the patient. And if the patient is telling, but of course, that sport is critical for me in life, we have to preserve that. The problem is that the vast majority of neurosurgeons doesn't know how to preserve somatosensory and bodily awareness feedback, even if the patient was awake into the operating theater, because they do not know the functional anatomy of the brain and never they will acknowledge it. This is the point. So to help younger people, last year we modeled, because we have to be first of all neuroscientists, the principle of cognition, namely the intention of complex action and movement volition, including so the frontostriatal tract, the frontal ascending tract, the somatosensory feedback, the SLF, superior longitudinal fasciculus between the pre and retrocentral area, and so on and so on. And not just the pyramidal pathway. How do you want to identify this complex network under general anesthesia? We have to be honest and to avoid to lie. The answer is we cannot. So please be honest with the patient by telling, I will avoid hemiplegia, and that's it. And if he agrees, perfect. If he says no, then you have to adapt your surgical strategy based on your adaptation of your knowledge of the brain. This is true for optic tract. What means non-dominant hemisphere? If the tumor is right, if you cut the optic tract, then the patient will have a left hemianoptia. Once again, in France, you cannot drive. You will lose your job. And we say, oh, we do not care. The patient is not hemiplegic. He's still autonomous. Yes, but he can't drive. He cannot work. I do not care. I will remove the tumor. Are you sure it's really in agreement with Hippocratic oath? Speaking about spatial awareness, once again, in the so-called right non-dominant hemisphere, we know that, we discovered that the layer 2 of the superior longitudinal fasciculus is critical to avoid hemi neglect. So for the spatial awareness, you can publish in Science as a modest, humble neurosurgeon. And on the other hand, you can also give the opportunity to this patient to return the high level of dance 3 months later by doing a gala. But it was now 19 years ago. Do you think that you continue to progress, Duffau? Of course, because recently we published in Nature, now in Science, that if you remove not the SF2, but the SLF1 more usually, plus minus the cingulate bundle, including in the so-called right non-dominant hemisphere, the patient will have attentional disorders regarding the visuospatial processing. So it's not only hemi neglect, is the problem of attention. So we increased the level of knowledge. And now, of course, many neurosurgeons will say, oh, but we have to preserve so the SF2 and the 1. And yes, you have to preserve the quality of life of human beings in front of you. But it's not against the median survival. This is the reverse. And the vast majority of neurosurgeons cannot understand. More you stop according to the functional boundaries, more your patients will live better, of course, but longer also. For them, this is antagonist because they understood nothing about these interactions, the dynamics of the tumor, the reaction of the connectome. They think that everything is stable, rigid, tumor mass, localizationism, no movement within the connectome. They understood nothing. The most important is interactions, especially between movement and language, but it's just an example. So what about language? Once again, you need to preserve the frontal astral tract. Otherwise, the patient will have a mutism. They say the patient will recover. No, he can keep, for instance, stuttering. We do not care if the patient is living 25 years. You have not to decide. If the patient is on TV, he needs, of course, to increase the fluency. He cannot have an increase of reaction time. So in this case, you will preserve the fat. If the patient is telling you to stutter, I do not care, you can cut it to remove more tumor. Now, I will cut it à la carte. Definitely, you have to know the functional anatomy of the fat. 20 years ago, the fat was never described in the literature. So it's a very recent discovery. You have to understand that the so-called Broca's area, structurally speaking, the pars opercularis and triangularis of the left inferior frontal gyrus, okay, is not directly correlated to the Wernicke's area, the posterior part of the superior temporal gyrus. Only 20% of fibers, 80% are located elsewhere. First of all, you have the lateral part, layer 3 now, of the superior longitudinal fasciculus, running from the ventral premotor cortex, so the output, remember movies? When I induce speech arrest, 1, 2, 3, it was not within Broca's area. And it is true in 95% cases. Connected in blue to the supramarginal gyrus and the so-called Wernicke's area. articulatory loop. When you stimulate, the patient will have an heart failure. So that means that it's very frequent in my experience to stimulate the so-called Wernicke's area and to induce speech disorders. And when I say that, neurosurgeons cannot understand by telling, but speech is in front of the frontal lobe. No, it's a loop. Unfortunately, we do not know the anatomy. And the best proof is that we published in the first journal of neurology, brain, and it, of course, 2 years ago only, the function anatomy of the arcuate fasciculus revisited. So the most described fasciculus in humans since 1 century. So everyone thinks that he knows. We know nothing. Everything is wrong. The vast majority of the temporal termination of the so-called arcuate fasciculus is at the level of the middle temporal gyrus, the inferior temporal gyrus, and eventually very anteriorly at the level of the temporal pole. We knew that by doing dissection. DTI, stimulation, postoperative correlation with the cognitive scores and the lobectomy we did. Please do that in your experience every day. It's not expensive what I'm thinking and speaking about. It just, you have to be critical. This is true for the fasciculus. We have seen that already during the movies when I stimulated that semantic paraphasia. Okay, you know where to start. And the trick for the insular tumor is that the IFOF is running within the temporal stem, so the external capsule, so laterally to the anterior perforating substance. So no reason to have any stroke in the depth in insular tumor because you will stop according to the functional boundaries, the IFOF, even if you decided to leave 1 cc of residual tumor in the anterior perforating substance. Now, never DTI, fMRI, what you want will give you this kind of information under general anesthesia. The vast majority of neurosurgeons I know would like to continue to operate under general anesthesia because their comfort, not the comfort of the patient, about more than 1,200 awake surgeries I did because I reoperated 1/3 of my patients. The rate of aborted awake surgery, because it was a nightmare for the patient, is 0. So neurosurgeons do not want because of them, not for the patient. But never they will understand what I understood just by observation into the OR. You are now at the junction between the dorsal, phonological, and articulatory pathway, the ventral semantic pathway. You stimulate both. You will not have 1 + 1, phonological plus semantics, or just anomia. You will have jargonophagia. Okay, I know exactly where I am. I know. And I have visitors in my operating theater coming from the 5 continents, 60 countries for 20 years. And in all cases, they are telling me, how is it possible for you, Duffau, to know where to stop in the depth? Because jargonophagia. Because I have seen the junction between dorsal and ventral semantic pathway. But how you know it, Duffau? Because I described that. Because I am a neuroscientist. And because under general anesthesia, never you will understand that. Because DTI will never give you this information. Because you using your navigation, you will have a shift in the end. But when you stimulate, you have jargonophagia, you can say, okay, it's in agreement with the pre-operative planning, mental imagery, in agreement with the expectations of the patient, functionally speaking, I have to stop. Everything is full of logic, common sense. If you talk to the brain, because the brain is talking to you, of course, if the patient is under general anesthesia, the brain will tell you nothing. Speaking about the inferior longitudinal fasciculus, so more basally, as you understood, we started dorsally and now basally. It is absolutely critical for language access, lexical access, speaking about proper and common name. But I wrote that the ILF in yellow could be cut and the uncinate also, because it could be compensated in red by the IFOF. Direct pathway compensating indirect pathway. I was true, but not completely. Because now, if the direct pathway, the IFOF, is already invaded by the glioma before to go to the operating theater, remember what I said at the beginning of the talk. You have to deal with the fact that we arrived many years later. And the reorganization between and across network and within networks are different from patient to another one, and the glioma can migrate along the white matter tracts. So what we see on the preoperative imaging is not the truth. Now, if the IFOF is already invaded, and if you cut the ILF, you will induce an increase of reaction time for lexical access to find names. You will tell me, the patient is not aphasic, is able to answer. Yes, but with more reaction time. And so what? So what? It's directly correlated to the return to work. That means that into the operating theater, if the patient is still able to name, but needs more than 4 to 5 seconds in order to find the word, you know that it decreases very significantly their chance to return to work, especially by doing a multitasking. You remember many things simultaneously within a time constraint, 4 to 5 seconds. So you have a very good idea of the ecological consequences in the real life after your surgery during your stimulation. Yes, but just because the patient needs 6 seconds rather than 5 Duffau, you will stop. It depends on the expectations of the patient. It's à la carte. You think you know the anatomy? You think we know the anatomy? Once again, we publish in Brain, the first international journal of neurology, blah, blah. Just now, 2 months ago, a new fasciculus, not known, involved in semantic processing, the Arnold bundle. In fact, Arnold describes structurally 1 century ago. I'm sure you do not know it. Not, of course, the Arnold nerve, the fasciculus. And we described that it was constituted by 4 different subparts. We do not know the anatomy. How do you want to operate the brain with a high level of reliability? If I come till the basal ganglia, especially the striatum, when you stimulate into the contact of the striatum, you will induce another symptom, perseveration. The patient showed a cat, he will say, this is a cat, perfect. Now it's a dog. You stimulate, the patient will not say this is a dog, he will say, still, this is a cat. No possibility to change, to switch toward the new task, the new item, the new picture. You cannot live like this. But in the vast majority of teams, I know you have just a resident or chief resident telling during a naming task performed in isolation, yes, no. Well, in fact, just with a naming task, it could be hesitation, increase of reaction time, phonology, speech, semantics, perseveration, jargonophagia. So many informations giving you the absolute knowledge where you are into the world. If you are a neuroscientist, but once again, it's not forbidden. 4 years ago, we published this paper regarding the re-networking based on the truth into the operating theater. It's difficult to say that we are lying. This is the reason why it was published in physiological reviews. I insist about that because this is not a journal dedicated to surgery or to oncology or even to medicine. This is the Bible of human physiology. So that means that definitely We say localizationism does not exist. We have to think differently. Yes, but can you propose something else? Of course, it's exactly what we did. And then we started to see the interactions, the dynamics across circuits by telling we have to see interactions not only between movement, language, but also cognition, especially in the right so-called non-dominant hemisphere. If you stimulate the right IFOF, you will induce non-verbal semantic disorders. And I will show you that it's absolutely critical when you operate insular low-grade glioma, and not beyond the scope of this presentation, because when you operate insular glioma, the question is, in all cases, the same: where to stop. According to the functional boundaries, yes, but before we are in the right. Awake the patient, yes, but we stimulate and nothing happens, because you have to think differently according to non-verbal or according to mood. And then you will identify the right IFOF, and then you will identify the temporal stem, which is just lateral to the anterior perforating substance, and you will not have any stroke. Interactions between cognition and mood is absolutely critical. Once again, I try to be totally objective by asking to neuropsychologists and neuroscientists to perform very accurate examination of my patients many years after my surgeries, even if they are still alive, working, and so on and so on. As you can see, I had approximately 25% of patients with modification of the mood, especially irritability, hypoactivity, disinterest, depression. So is it possible to change the way? Yes, by understanding why. And because we cut fibers. I cut fibers. And you know where? Especially in the right non-dominant hemisphere. So I said, no, I have absolutely to preserve that into the OR. If the patient agrees, once again, à la carte, but I can propose it. Do you want to preserve the emotion? Duffau, you're totally crazy. You think you can preserve emotion into the OR? Of course I can. We demonstrated that by introducing new tasks, especially to recognize the emotion of faces in front of you into the OR. And when you stimulate, it's very, very frequent for the patient to say sadness rather than happiness. Inferior frontal gyrus could be involved, could be anatomofunctional variability between patients and in the same patients over time. The right broca, sometimes more important than the left, speaking about mentalizing, but also the dorsolateral prefrontal cortex, but also the posterior part of the superior temporal gyrus. In other words, not one area, a network, and this network is underpinned by the right inferior frontooccipital fasciculus. So into the operating theater, the patient is awake. You stimulate the right IFOF in the depth in order to know where to stop because you are doing an insular surgery. And nothing happened during the non-verbal semantic task. And you think Duffau is totally crazy, it does not work. Except if you ask to your neuropsychologist at the time, can you switch to another task, the mentalizing task, please? You stimulate and suddenly, oh, problems. Okay, I understood. I know where to stop. And this is true for the cingulate also, not only the IFOF. The IFOF is involved in so many tasks, so many functions, including in the right so-called non-dominant hemisphere. We have seen nonverbal semantics. We have seen mentalizing, but it's true also for self-evaluation. Do you know what you know? Are we aware about the fact that sometimes we do not know? Without this answer, you have anosognosia. You think that it's possible to enjoy normal life with anosognosia, even if you are not hemiplegic aphasic? You know the answer. The answer is no. But you think before that you can preserve it. It's very easy. You can ask to your patient after what you want, just a naming task, a mentalizing task, what you want. Within the same time constraint, 4 to 5 seconds, not only to name, to give you an answer, but also to self-evaluate. And we use a scale from 1 to 6 in Montpellier, but you can do what you want. 1 means random. I don't know. Probably you stimulated and I said something totally wrong. I said a dog for a cat. You have not to say everything, just one or six. I'm sure. I'm sure. The problem is that if the patient said happiness for sadness or dog for a cat, six, that means that he's not aware anymore about the fact that he doesn't know. And it's related to your stimulation, especially at the level of the V4 and the cingulate. You have to stop. Otherwise, your patient will never return to a normal life. It's just an evidence. We modeled everything, including in these numerous papers. And today we submitted another paper in Brain, while past week another paper was accepted in Brain. And nonetheless, this week I did 3 OX surgeries in 3 patients coming from abroad considered as non-operable. So it's not incompatible. This is the reason why I can make the link between these neuroscientific issues and the clinical implication. And to demonstrate to neurosurgeons, I compared Duffau to Duffau. Duffau, when I was younger, surgery in the right so-called non-dominant hemisphere, and especially for right insular tumor, because I was one of the first to do it 20 years ago, 25 years, sorry, and under anesthesia initially. And finally, I was not so poor regarding my results because the externalization 90% and return to work already 82%. Almost 20% of patients not able to return to work. And I had 2 permanent hemiparesis, and at that time related to this stroke. Why? Because I did a sleep surgery in the right so-called non-dominant hemisphere, and I didn't know where to stop in the depth. And then I went too deeply into patients, and I induced, of course, damages of lenticular striate arteries with 2 hemiparesis. And I induced also modification of the mood very seriously in one patient who had a very, very severe depressive syndrome. Okay. One day I said, okay, I have to stop now. I have to wake all patients, including in the so-called non-dominant hemisphere, then to introduce the tasks you have seen, non-verbal semantics, mentalizing, self-evaluation, blah, blah. Okay. Suddenly what happened? No neurological deficit. Return to work, more than 95%. And you will tell me, but you will leave more tumor. No, no. The extensivization is the same. So do you want to change your mind and to have better results with the same externalization and much more quality of life for your patients, or to continue to apply the classical dogma by telling, oh, I don't know where to stop when I will not feel the tumor anymore. It was true 40 years ago, not today. So to about more than 1,200 awake surgeries in inoperable areas, according to the vast majority of neurosurgeons, because in the Wernicke's area behind the Labe vein, because in frontal areas, so-called Broca's area, in the central system, in the corpus callosum, in the blah, blah. Okay. No brain plasticity. Remember the 3rd slide of this talk. Mortality, 0. It's not forbidden and not expensive to have a good team, good anesthesiologist, and so on. 0.5% of severe permanent aphasia, the 2 patients I spoke about when I was younger, and it was not, in fact, in awake conditions. 86% of cognitive preservation. This is unique in the literature. Of course, because first of all, in order to say that, you have to do systematically pre- and post-operative cognitive assessment, which is not done in 99% of neurosurgical department in the world. Why? Plus 10% of cognitive improvement. Many neurosurgeons cannot understand. Duffau, you are telling me that the patient is well before surgery, you remove Broca's area, and is better after that. Of course, because first of all, it was not well before surgery. You did not perform cognitive assessment. But by doing that, you could have some decline of verbal working memory due to the loop, for instance, involving executive functions, and the patient was still able to work and so on, but it was not perfect. Second, Broca's area does not exist. You have to preserve the connectivity and its reorganization induced by the tumor over years before the diagnosis. Third, postoperative cognitive rehabilitation. Fourth, return to work, which is critical for pushing the brain, of course, to work and then to continue to learn, then to induce plasticity within the next years to decades. And if you put everything all together, yes, you can remove Broca's area in a patient before surgery and to be better 6 months later. And if you cannot understand, you understood nothing about the brain. So you cannot operate the brain. This is full of common sense. Why it's not applied everywhere? We're afraid by the brain, but we are brain surgeons. Not to be afraid means to be connected, to accept that the brain is telling you, be careful. Here, stop. This is the limitation of the dynamics. Or to say, please push more. What means Wernicke's area? I continue to process normally. Be careful now, this is the connectivity. Stimulate me, and so on and so on. The brain is talking to me for 25 years. And you see my results. 94% of return to work, and I cannot lie because 90% of my patients are coming from other centers. This is unique in the literature. But why? Once again, it's not to say I operate well. It's to say everyone should achieve exactly this kind of results. 80% of positive impact on epilepsy, especially if you remove more widely than the tumor core itself. Remember the second slide of this talk, I said you have to consider the diffuse glioma feature and to try to remove more according to the functional boundaries if functionally feasible. And then, okay, Duffau, if you do supratotal then you will increase the median survival, but the patients are not well. Of course, they are better. Because in low-grade glioma, epilepsy is related not to the core of the tumor, but the periphery. So more you remove the diffusion around, more you will control seizures. And if you control seizures, your patients are better. It's crazy to speak about dilemma, antagonism, and so on, while in fact, everything is so full of common sense. I say that 3 times. So not yet published, and in fact submitted now for the first time in the literature by selecting IDH mutated grade 2 glioma, the overall survival is beyond 20 years, not yet reached since the first surgery. More than 23 years since the first symptom. But with preservation of the quality of life for 15 years. This is unique. And now I hope you start to understand how it was possible by dealing with the connectome. You will tell me, yes, but you selected the small tumor, especially incidental tumor, it's easier, blah, blah. No. We published past year because I heard that so many times in Journal Neurosurgery, the sole series in the world with only patients with low-grade glioma or lower-grade glioma with more than 1 cc. Yes, Duffau is a neuroscientist, at least twice, but it's not incompatible with the fact that I can do very extensive lobectomy. I'm not afraid about that. You understood why. Subpyral dissection, connectome-based surgical resection, intraoperative cognitive monitoring, knowledge of the function anatomy and dynamics between networks. Okay. The median survival is also 3 times more in bigger tumor. Because remember, when I started, median survival was 6 years. It's not me, just objective, published in JASIO. Now, more than 20 years. Of course, in this series, you have also some patients. I did very extensive resection according to functional boundaries, and I developed the concept of supratotal resection, which is now very fashion. But when I published 12 years ago, everyone told me, you're completely crazy. Really? To remove the tumor in diffuse tumor? No, to remove the brain. But it's not a normal brain. It's a tumor invading central nervous system. Yes, but where to stop before? According to the functional batteries. But how to map that? Not to map, to monitor according to the better understanding of the meta network of networks. And when I answer that, okay, no one understood. But it's a pity. How do you want to operate the brain if you have not understood the concept of interaction within networks and between networks? And suddenly what happened by doing supratotalization in this subgroup, 99% of patients still alive with a normal life, with no radiotherapy, because radiotherapy is not good for the cognition, maybe within 5 years, but not in patients living 5, 10, 15, 20, 25 years. For the first one I operated on, still alive. So please operate earlier and earlier. And if you have the chance, the patient has the chance to have a discovery of a small lesion because the first seizure or incidental discovery, so please remove it and you will suddenly see an increase of the rate of supratotalization. And what will happen? No permanent deficit in this subseries of supratotalization. Yes, but Duffau, it's true only in Montpellier. No, we validated by Italy, Canada, UCSF, and so on. In this paper we published 3 years ago regarding the resection of incidental low-grade glioma, that the median survival was not yet reached, of course, but the 10-year survival was over 93%. But we were sold to provide the cognitive examination after surgery, sold. And we were the sole to provide the rate of return to work in the subgroup of incidental discovery, 97%. And my goal is to say, yes, we are very good. My goal is to say 3% of patients working normally before surgery were not able to work normally after my surgery. I was responsible. So how to improve and to done toward 100%? This is the question I ask to you, the young generation, because once again, you do not need intraoperative MRI to achieve this kind of results. So we proposed in the population to do screening between 20 and 40, especially because, of course, this is the peak of diagnosis for low-grade glioma. And we started really to propose to have MRI, for instance, because your father died from a glioblastoma. And if we found imagine very typical for a tumor, then to propose supratotalization. But I cannot cure patients, even with a supratotalization, even with a preservation of the quality of life, even if a return to work, even if no chemoradiotherapy, even if you will see after 10 to 20 years, in all cases, a rim of flare hypersignon, which appears again. It's a diffuse disease. So what to do? To listen the brain, but not only into the operating theater, but over years. Brain plasticity. And once again, we have to understand what happened before the diagnosis. And we did that especially for low-grade glioma involving the insula, because as you know, it's very frequent. I don't know why, but this is very frequent. And we demonstrated that before any treatment, the patients with low-grade glioma involving the insula had an overcompensation thanks to the contralateral side, with an increase of the volume of the cortex, of the normal cortex on the contralateral side, an increase of the morphometry in adults. So an increase of the functional connectivity, explaining why finally you can do a lobectomy of the inferior frontal gyrus and the insula and so on, and just preserving the connectivity in the depth, the height of the ventral semantic pathway, and your patient will recover because he compensated of course, also before surgery, but we have to understand the mechanisms. And you know what? They are different from one patient to another one. At that time, fMRI is magic because non-invasive. Then you can have baseline before surgery, but you can do, of course, fMRI during the transitory postoperative worsening, for instance, after SMA syndrome, and then after recovery, because the patient accepted to have SMA syndrome. Perfect. So recover, not perfectly, but he's not a high-level pianist concertist, so he doesn't care. Perfect. What are the mechanisms? And as you can see, the recruitment of the contralateral homologous. What means non-dominant? You need a network involving both hemispheres. We did that using resting state fMRI. And we demonstrated that during the SMA syndrome, there was a decrease of the connectivity, functional connectivity, between hemispheres. And throughout the rehabilitation, the patient increased their connectivity, again, functional connectivity between hemispheres correlated to the quality of recovery. So the dynamics between networks and between hemispheres. Recently, past year, in Brain, we published for the first time first surgery cortical mapping in hundreds of patients compared to second surgery modification of the maps. But these modifications are not similar from one patient to another one. So different pattern of reorganization. And then we have to anticipate that because the solution to oncological problem we can patients Duffau, and even if you do supertotalization, then you will see a reprogression of the tumor, recurrence, relapse a few years later. Then the solution will be to come back and to remove more according to the mechanisms of reorganization occurring in the meantime. But now, not in the meantime before surgery, but after the first one and before the second one. And then you will remove more tumor. And then your patient will continue nonetheless to enjoy normal life because you preserved the connectivity. The summary of this slide is that the cortex is very plastic because many redundancies. Why? When you have a convergence of fibers, you have less and less plasticity. I tried to explain that past year to neurosurgeons. So in your journal of neurosurgery, not in Science, Nature, Physiological Reviews, or Brain. Journal of neurosurgery. I took the example of glioma, low grade if you want, at the level of the insula, because very frequent. You use the microscope. I do not use it because I need to see the connectivity in 3D and 4D also the reorganization. And you feel the tumor under a microscope. And you would like to remove more in the depth because it's in the right so-called non-dominant hemisphere, and the patient is under general anesthesia, and you will not ask him or her, in essence, to do the mentalizing task or the non-verbal task or the multitask or, okay. You will cut 3 millimeters of the IFOF in the external capsule. And you will say, it's just 3 millimeters. No. It's a disconnection of 1/3 of the hemisphere in black on the right side. You disconnected 1/3 of the hemisphere by pushing the resection in the depth at the level of the convergence of the different layer of the IFOF, the most important part, network bundle of human beings. You disconnected 1/3 of the hemisphere under microscope by pushing 3 more millimeters. You have to understand that. You have to feel that. You have to think about that by sleeping. You have to encode that in your autobiographic memory. You have to encode that in your genome. Otherwise, you cannot operate the brain because, of course, your patient will never return to normal life. You disconnected 1/3 of the hemisphere. This is the principle of disconnectionism. You have then to do a resection according to the connectome. It's simple. You will come back a few years later, of course, without radiotherapy, which is dangerous for the brain plasticity and not necessary if you want for your patient to live longer and better. No early radiotherapy. You will come back 5 years later. Duffau, you left a small but objective amount of tumor. Yes, it was at the level of the so-called club of the hand. And 5 years later, you remove the club of the hand in a patient able to play guitar because I preserve this full connectivity. Same thing regarding, for instance, the vernicose area. It was not possible. You see, Duffau, that the vernicose area is critical. No, it depends on each patient, and it depends in the same patient if it will be 5 years later, 10 years later, or not. Everything is dynamic, changing. You can do a very extensive lobectomy 10 years later in patients in general life because you preserve the connectivity in the depth. 50 means the ILF. 46 means the inferior frontooccipital fasciculus. Then above you have, of course, the arcuate fasciculus running to, you remember, T2 and T3 and not to T1. You can do sometimes a very, very provocative bilateral frontal lobectomy, but not by removing both lobes simultaneously 10 years later. And in the meantime, the patient enjoys normal life. And then mechanisms of neuroplasticity induced by the regrowth of the tumor. Otherwise, why to come back? But we can cure patients with diffuse glioma. And finally, you will remove the second lobe 10 years later with a perfect preservation of quality of life, patients able to drive to work and so on. Are you sure you will change something Duffau by doing so many resections? Yes, we published that. First resection, second resection by removing more brain invaded by the tumor. Third resection, and so on and so on. Median survival, more than 18 years. You will tell me, but you spoke about more than 20 years. Yeah, but in this subseries, you have grade 2 and grade 3. So you can change radically the natural history of the disease of with also high-grade glioma. Oh, Duffau is just taking care of low-grade glioma. It's so easy. No. Low-grade glioma does not exist. And finally, even the WHO classification started to speak about lower-grade glioma 2, 3. We say that 20 years ago, a continuum between 2 and 3, where to decide to have a cutoff. That means nothing. Are you sure that by doing a second, a third surgery, and you will not at that time induce a decline of your cognitive functions? No, we did systematically a cognitive assessment after reoperation, and the rate is the same. 94% also of return to work after reoperation because we know the limitation of neuroplasticity. Yes, you know Duffau because you are involved in that. No, we publish atlases in the MNI template. They are available. You can use them if you want in order to avoid waste time, to build your mental imagery. And of course, the limitation will be the input-output. If you cut the calcarine fissure, of course, the patient will have heminaptia, or if you cut the pyramidal pathways, the patient will have hemiplegia. Okay. But otherwise, the main limitation is not the cortex, is the connectivity, associative fibers. And you know what? When the oncologists are telling you you have to do systematic and earlier radiotherapy, eventually combined with chemotherapy, because you will increase median survival. No, the median survival in this paper by Van den Bent in Lancet 20 years ago was 7 years. In my series, it's 20 years. But with preservation of the quality of life, because when they irradiate, they take a margin. Of course, it's a diffuse tumor. And then they irradiate the connectome, the limitation of neuroplasticity, the subcortical white matter tract. They're not aware about that. So we will induce a decline of the cognitive functions. Maybe not after 1 year, but we are not speaking about glioblastoma. But after 10 to 20 years, it will be a nightmare. And it's not only true in Montpellier. You see that 2 years ago, it has been published by colleagues in Belgium. I changed nothing. Cognitive and or emotional disturbances in about 50% of patients after radiotherapy for low-grade glioma. So do not irradiate too early. Nonetheless, in the classical and current guidelines, what they call personalized medicine is finally to do chemoradiotherapy in all cases, except if you did a complete radiation under 40. And that's it. You think really it's personalization? I would like to see the long-term results. You have mine, about 1,000 patients. We have never seen the results of people doing the guidelines. So we decided not to apply these guidelines, knowing that the guidelines are changing every 5 years. We are not changing. We are adapting to the patients living more than 20 years. And especially by doing chemotherapy when you cannot reoperate because the diffusion at the level of the limitation of neuroplasticity, including the contralateral connectivity. And at that time, we will do not radiotherapy, but chemotherapy. So, oh, it does not work if it's not an oligodendroglioma 1p92 co-deleted. Stop. Of course that works. I am a neurosurgeon. I'm not giving a chemotherapy by myself. I have seen so many patients. I mean, 80 to 90% of patients with an astrocytoma with at least a stabilization under chemotherapy, and 1/3 with a shrinkage. And when you have a shrinkage, you can reoperate. Because the invasion of the limitation of neuroplasticity, the connectivity. You cannot speak about that with neuro-oncologists. They do not know the brain. So we proposed dynamic models adapted to the dynamics of the brain by telling operate, induce plasticity, by doing postoperative cognitive rehabilitation, by pushing the patient to return to normal life, and so on and so on. Come back a few years later, before malignant transformation. Again, according to the functional boundaries, but modified because the brain is dynamic over years. And again, no early radiotherapy. And come back if you want. If you cannot, then do chemotherapy, then induce shrinkage. Maybe today it will be possible to add the anti-IDH to the armamentarium. We do not know because we have not enough follow-up, but in 5 years we will know. And finally, postpone radiotherapy. And one day, because I cannot cure patients, because regrowth, because reoperate, and because we use temozolomide and PCV. Finally, after 15 years, we will irradiate the patient. And we will be so happy to have the radiotherapy at that time, because you know that you cannot irradiate. You know that in the vast majority of cases, you have already some foci of malignant transformation in the middle of the tumor. Sometimes 3, I spoke about that already, sometimes 4. And of course, according to the guidelines, we have to do a STOOP systematically. If I did a total or supratotal, you told me I was crazy to would like to remove more than the flare, and now you are telling me, oh, finally, patient is well. Thank you, congratulations, and we have to irradiate. Because one focus on malignant transformation. You said one focus in the middle and not everywhere, so just in the middle. And the rest of the tumor was low grade. So why to irradiate? Because I did a supratotalization of the focus. Because this is the guideline. No, I speak about the patient. And remember, I calculated the growth rate before to go to the operating theater. And if the growth rate was rapid, you're right, I will be the first to propose adjuvant treatment. But if the growth rate was slow, in essence, that means that the tumor was not already aggressive. Of course, before it's aggressive. No, in the middle. And I did a supratotalization. I will not do systematically chemoradiotherapy. You are crazy. Okay? You can see my 5-year survival rate in this subgroup. Oh, more than 95%. I cannot believe it. You cannot believe also that it's possible to remove brochocerian and to be better after surgery. Example, you see the real enhancement before my first surgery in the left dominant superior parietal lobule. I did the supraclavicular resection according to functional boundaries. It was in 22. So 22 years ago. And I say, no chemotherapy, no radiotherapy. Oh, Duffau, you're crazy. Yes, but 2017, I cannot cure the patient, but she enjoyed her normal life. And I say, I will reoperate you because mechanisms of neuroplasticity and so on. No chemoradiotherapy, because at that time, according to the new classification, it was a low-grade glioma, while it was a high-grade glioma 20 years ago. Of course, there was a focus in the middle. And you know what? The patient is still alive with 22 years, no chemoradiotherapy. And I was the first during the last meeting we had with this patient 1 month ago to say, there is regrowth. I cannot reoperate you. I would recommend to benefit from chemotherapy for the first time after 22 years in a high grade. And it seems that we are criminal not to apply the protocol, and this patient was never irradiated. She's very happy. I have hundreds of patients like this. In other words, it's possible to apply the same concept of supraclavicular in high-grade glioma. And once again, each time I want to validate something, I ask colleagues to do it for me and to obtain the same results or not. And in Italy, the team by Silvio Cervibo demonstrated in high-grade glioma after learning in Montpellier many years ago, and now able to reproduce exactly the same thing, that if you push the resection in high-grade glioma, you preserve the quality of life, the neurocognitive issues, but also the median survival. It seems that everyone is very interested by the quality of life of patients. Oh, really? We published the sole meta-analysis regarding the return to work after low-grade glioma surgery in the literature 2 years ago. And about thousands of papers, only 19 asking the question, what about the return to work? Of course, it's not so important in patients who, in the vast majority of cases, are living between 20 and 50. So the work is not really one of the priority. Now, the priority is the PFS in order to demonstrate that radiotherapy has an impact for 2 years. It's very helpful for the patient to know that. But they know that many patients, they are living longer and returning to work in 95% cases. How many studies are interested by the sexual activities of patients with low-grade glioma? It's not really critical. They have between 20 and 50, and the sexual activity in order to enjoy normal life is without any interest. 3 studies, including 2 from Montpellier. Critical and pathetic to see that finally everyone's speaking about quality of life of the patient, but meaning more or less so the patient is not hemiplegic, and that's it. I will go beyond. Of course, because my patients are living longer and longer, in women, they would like to have a baby. Be careful, because there are negative interactions between pregnancy and natural history of the disease, which is not really natural at that time. We do not know mechanisms, but I know, unfortunately, that 50% of my patients after pregnancy, while the low-grade glioma was under control before pregnancy, died in 5 years. There is a problem. But we identified that if we did at least a complete resection according to the flare, then suddenly they had a chance to live longer. So to adapt the real personalized strategy. It could be possible sometimes for me to propose to a patient who would like to be pregnant to reoperate her by dealing at that time with mechanisms of neuroplasticity which occurred since the previous surgery in order to tend toward a complete resection and to decrease the risk of modification of the behavior of low-grade glioma during and immediately after pregnancy. This is personalized strategy. How do you want to put that in guidelines? This is possible the functional anatomy of the brain. So I know now you have a risk to have seizures by saying so many informations here, but I never say that the brain was easy to understand. But to help you, we published 4 years ago the sole atlas in the literature dealing with different functional domains, 16, and giving you the critical structures, both at cortical and white matter tract level, in order for you to better understand brain processing. I mean, it's not DTI, it's not statistics, it's not, remember, DTI is not a function. This is the function based on thousands of intraoperative electrical stimulation sites, especially at the level of the white matter tracts. So you should have this atlas in your mental imagery. Of course, by dealing after that with the inter-individual and intra-individual anatomo-functional variability. But at least you have a basis. And now you can put the dynamics between hemispheres, within hemispheres. This is the concept of meta-network. I mean, your brain changed in 1.5 hours since the beginning of this talk. So how do you want to compare two brains? Because yours changed dynamically just in less than 2 hours. So when you have to solve a problem in life and to go to a specific goal in order to be adapted, to have an adaptive behavior, you need to use different networks, maybe language, maybe a little bit more semantics, maybe movement, maybe mentalizing, maybe and so on and so on. And to combine in order to say, okay, I have a chance to solve this problem. This is exactly by using, if you want, now DTI, fMRI, and so on, but by understanding that without your own mental imagery, you will never succeed to go beyond my own results because DTI is not a function. But we helped younger generation by publishing this kind of paper, summarizing that in something more understandable for neurosurgeons. But by understanding also that this is a simplistic view, giving you just a background, and then you have to continue to evolve by making the link between neuroscience. And it's exactly what we did by publishing this paper in Brain recently and combining not only intraoperative electrical stimulation, but also DTI and fMRI, resting state, and so on and so on. So this is only research, but it's not forbidden to do research. And it's not incompatible with the fact that your patients can live longer by doing very extensive resection. Why? I do not use any technology. So to conclude, if you start to deal with the dynamics of the brain, you can predict before to go to the OR approximately how much you will remove and if the patient will recover according to his expectations, because you know the interactions between so many networks we have taken. Second, into the OR, once again, you can have some insight into the real active life or not that the patient will resume after your surgery, typically by doing multitasking, selecting tasks, reaction time, and so on. So you have a choice to stop earlier according to the moral contract you had with the patient, according to his her needs, à la carte, according to your knowledge of the functional anatomy into the OR, because the reaction time just increased, while the patient will not be aphasic hemiplegic. But he told you, I am a medical doctor, I want to continue to take care of my patients. And definitely you will come back. But you will come back after inducing plasticity. And it does not mean that because the patient had transitory language disorders after surgery, then you have to rehabilitate only language. You have to increase the link between language, attention, executive functions, working memory, mental flexibility, emotional processing, and so on. This is the principle of the rehabilitation according to the meta network, and not to see each function, each network in isolation. And definitely, you will be able to predict when to reoperate the patient and if it's possible or not, or if you have to go first toward neoadjuvant chemotherapy according to the diffusion within the white matter tracts, the limitation of neuroplasticity. You see, everything should be now just logic. My dream would be to induce not only plasticity, but modification of the pattern of plasticity, especially thanks to better understanding of the meta network, but also maybe inducing plasticity thanks to rehabilitation, but also maybe the use of RTMS, the principle of meta-plasticity, plasticity of plasticity. What means? You are in front of a patient because first seizures, because diagnosis of low-grade glioma. And you have understood that unfortunately for you and for him, her, the brain was able to compensate for many years, explaining why the patient is well except the seizures, thanks to a perilesional mechanisms. In other words, when you will remove the tumor core and you would like to take a margin around very early, quickly, the brain will tell you, stop. You cannot because the periphery of the tumor is the critical network explaining why the patient recovered. So you have to preserve it. And we hate that as neurosurgeons, of course. While if there was a compensation thanks to the contralateral hemisphere, mostly, then of course it could be possible to push more authorization to the supra-authorization because you know that there is a compensation thanks to the other side, like in the example of low-grade glioma involving the insula I showed you. So my question is, do you think that it's possible in the same patient over years to switch from a perilesion to a contralateral mechanistics in order, of course, to push more plasticity according to what you would like to achieve, namely reoperation by taking a margin around? And to be honest, the answer is, I don't know today, but it will be one of the main topic I will work with for the next future. And finally, of course, I hope you have understood that if you do not understand the natural story of the disease in the individual case, you will not adapt a perfect strategy. But in all guidelines based on oncological issues we have seen, never they are dealing with limitation of neuroplasticity, connectivity in the depth, possibility of reorganization, and to switch from one mechanism of plasticity to another one, brain instability. Neoadjuvant chemotherapy inducing more mechanisms of neuroplasticity. Radiotherapy limiting the mechanisms of neuroplasticity, and so on and so on. How do you want to take care of a human being with a chronic disease, with brain reactions, without taking into account the dynamics of the brain? Simply, it's impossible. And I'm afraid about the fact that I will have to spend 10 more years to explain that to neuro-oncologists, surgical and medical neuro-oncologists, why just full of common sense. So for younger people, neurosurgeons, be careful about technology into the OR because it's the best way to mask your lack of knowledge. So you will be addict dependent on technology, but the technology is wrong. And never you will reproduce these results. And never you will continue to improve these results because my patients are not here. So please be careful about evidence-based medicine with the surrogates like PFS, which is absolutely not correlated to the overall survival. You have to be patient and to continue to do the collection of your own data as medical doctors, especially as neurosurgeons. Be careful when you speak about your MRI is stable and you're very happy in front of the patient, but he doesn't care. What he wants is to live longer and better. So deal with your improved knowledge of the connector, become your scientist, and propose new model than I did in my life. And then you will probably continue to push also the surgical strategy according to that. It's not incompatible. It is directly related. And in practice, what means? I will now submit a paper for the first time in the literature. Patients I operated on 5 times, not because malignant transformation 2 years later, but after 20 years, preventively each time to remove more brain, thanks to mechanisms of neuroplasticity, without chemotherapy, without radiotherapy, with normal life, and maybe the possibility to live 25 to 30 years. I don't know yet. I will tell you in 10 years before my retirement. So the message is very easy. See the brain, then you will better operate the brain. Then the brain will give you some information in order to better see the brain, to propose new models, which are very important also for fundamental neuroscientists because they are not connected to the brain. They need an interface. They need statistics, models of biomathematics, DTI, fMRI, but we are connected to the brain. And suddenly, you will see that you will be helpful for your society, not only in neurosurgery for me, but also in oncology, but also in neuroscience, but also in neuroanatomy, but also in neuroradiology, but also in neurophysiology, but also, okay, you have understood. But why? It's not done systematically. I mean, it just to be connected to the rest of the world. And I am invited in so many societies. And you know how many neurosurgeons I can see with this translational view? No one. It's a pity. So if I can do it, and because my patients are living longer and better, but I cannot cure them, please try to go beyond by finding your own style based on multimodality in your brain and not by telling, first of all, I will start to operate. I will learn to operate as a classical neurosurgeon. And one day I will become a neuroscientist. I will better understand the brain. Then I will make the link. Then I will think 10 years later, forget it. The brain is not processing like this. You need to do simultaneously everything. And the best proof is that my poor English, because I learned too late and I can continue to do thousands of talks, I will not be able to speak fluently English. While if I learned when I was under 10, then suddenly, of course, it would have been an evidence for my brain that you could speak very easily different languages. It's exactly for you the same thing now. If you wait too much, you will never become a neuroscientist. And then you will never be able to operate the brain with high level of reliability. So good luck for making your own decision. And I hope that the discussion now will allow you maybe to see everything more easily, because definitely we have to work a lot, but the brain's magic and everything is, to my opinion, once again, logic within the brain, and you have not to be a genius in order to see the truth if you forget what you think you know today based on wrong dogmas and based on your own creativity. Good luck.
Thank you so much, sir. It was a wonderful talk, and not only you told us so many things, but you guided us to think, to have a newer view and to have a better view of this condition, and this means so much. So we were all so much impressed, and we were so much deeply immersed with with everything that you have taught to us. So, sir, again, thank you so much, and I want to reiterate the fact that neurosurgery, why we consider it a superior field, why we say it's the creme de la creme of all the specialties, is because it is the academics and the research and the logic and the thinking process that distinguish a neurosurgeon from anyone else. Because we don't need just a knife, we need a lot of academics, we need a lot of thinking, we need to use our own brain. And it means so much, sir. I really wish to thank you to highlight this important thing, and to highlight the that neuroscience is basically an integral part of neurosurgery, because many of neurosurgeons unfortunately consider that neurosurgery is all about operating, and they do not have anything to do with the logic and the academics, the research that has been taking place. It's a dynamic field. So again, I really wish to thank you for all this amazing talk and all those wonderful things that you told us, and the way you actually taught everyone to think. And that really means a lot, sir. Sir, I also want to reiterate the fact that achieving the on-co-functional balance is is of paramount importance, and this is what you have always been advocating. And everything that we see is actually much deeper than what we can think of. So again, sir, thank you so much, sir. There are a few facts. You have so many wonderful papers. You have so many wonderful textbooks and chapters, and all of us we go through all of them, and we give references and cite them too. So, sir, there is a fact that the low grade gliomas, they actually do this neuroplasticity, and the neuroplasticity depends upon the location of the tumor, with more, I think, with frontal and temporal having a more propensity to this plasticity. And so there is also another fact that we think is there that seizures which can be seen with low grade gliomas, they actually are a limitation of neuroplasticity. And I think you have also mentioned in one of your wonderful papers that resection of glioma and not only leads to seizure control, but also it has a better prognosis to neuroplasticity, since the presence of seizures is basically a limitation for neuroplasticity. So how do you actually see that the seizure control and the preoperative seizures can have an effect on neuroplasticity? And also, sir, there is another fact that sometimes you have also mentioned in the talk as well, that the gliomas elsewhere, and it's affecting an eloquent area far away, that is remotely located. So how all these things and plasticity are quite relevant. And so there's another point that is in my head, is that those glioblastoma that arise, that is secondary glioblastoma that arise from the low grade gliomas, how do you think that all these things are integrated in the secondary glioblastoma, because it has been arising from the low grade glioma that was already present? And as we know that the high grade glioma does not have, it disrupts the centers, and it does not lead to that sort of very nice reorganization that is being seen with low grade gliomas. And again, that can be adaptive and maladaptive, both of them, in even the case of low grade gliomas. So it's a bit of a complicated jargon that seems a little bit more complicated. I really wish you to kindly enlighten us about this fact.
I think that, first of all, this paper, as a didactic tool, it should be, can help you regarding the first question, but also related to all other questions you raised. I mean, you have a specific location for a tumor. Of course, the network is dynamics and using both hemispheres, but in the vast majority of cases, there is one tumor diffusing around what we can see, okay, but with a seed at the level or the SMA or the insula, I must acknowledge that. And this is the reason why We published this paper telling, according to the location of the tumor, then you have to be careful about the different pathways you should encounter in the end, especially if you would like to push the resection according to this limitation of neuroplasticity, but not before. And typically, here I illustrated an example of insula. But in this paper, you have the SMA location, you have the temporal location, and so on and so on. And when I am in meetings, if I take the example of SMA, the vast majority of neurosurgeons will speak about the pyramidal pathways posteriorly. Some of them, eventually, the frontostriatal tract and the fat. But no one will speak about the lateral part at the level of the part 2, layer 2 of the superior longitudinal fasciculus, or the inferior fronto-occipital fasciculus running within the dorsolateral prefrontal cortex. Nonetheless, what we have seen in the movies. So that means that we miss in our mental imagery many tracks. And if we start to see them because they are there, of course, you can select by telling, okay, today I decided to cut the fat because, and I hope that the patient will recover. It will be your decision, your responsibility, according to the discussion you had with the patient before. But without this knowledge, no way. So it's my first answer, which is directly correlated to the fact that, of course, more you remove, more you will control seizures. So seizures could be a problem if the patient, of course, had intractable seizures before surgery. But I insisted on the fact that we have to operate earlier and earlier, and we have also to inform, educate neurologists, and not to keep the tumor by telling, oh, it's a benign tumor, we have to follow them until 4 anti-epileptic drugs per day. No. And more, you will remove around the tumor core. So according to these functional boundaries, so this knowledge of the different tracts, according to the location of tumor, then more, you will decrease the rate of postoperative seizures. I said approximately 80% of improvement, which is not new in the literature, of course. And then, of course, you will give more plastic reserve again to the brain, which will be able to relearn after your surgery, thanks to cognitive rehabilitation, but thanks to less or no seizures anymore and a decrease of the anti-epileptic drugs. So it will be a positive loop you will induce thanks to your more larger resection than the flare itself. Typically, in the temporal lobe, I have the habit regularly to remove the hippocampic structures, mesotemporal structures, even if not invaded according to the preoperative MRI, if the patient had intractable seizures before surgery because it was referred to me a little bit too late. And then I will try to mix both oncological surgery and epilepsy surgery in the same time in order to improve the quality of life after a few months. Which is also true speaking about glioblastoma. Because, of course, if a patient is 80 with a butterfly glioblastoma and with MMS around 10, I will not propose to operate. I will just do a biopsy if the family would like to give all chances to the patient to have maybe 3 to 6 more months under chemoradiotherapy, but without improving the quality of life. So in this case, I will not operate. Why I know that I am in meetings like AANS, they are telling, oh, you can use the endoscope, you can remove butterfly just using a small burrow with very few complications. But this is not the goal. The goal is to say to the patient, do you want to live longer and better? And in this example, he will answer nothing because he's not able to understand what you are telling before surgery. So I will not operate. But if you are 50 with a glioblastoma in the right, left frontal temporal lobe, and the patient is well, more or less, he starts to have decline of cognitive function. He had seizures, sometimes not, as you know, in glioblastoma. Of course, I will apply exactly the same concept. I will do awake surgery, even in so-called right non-dominant hemisphere, I will do not a resection of the enhancement. We do not care. You will change nothing plus 3 months. But a lobectomy according to the functional boundaries and then adapted to this patient because the capacity of compensations were less than in slow-growing low-grade glioma, of course. So in the vast majority of cases, I must be honest, I will not remove the flare like in low-grade glioma. But if you remove at least 50% of the flare in addition to the enhancement, you know what? They are living 3 years with a good quality of life, at least for 2 years. The vast majority of patients with glioblastoma, if they worked before, under more or less 65, they will return to work too. So the concept is exactly the same. And I will
Exactly.
push
So
more.
that's incredible. So there
Still
is one.
based, just to conclude, but you will see now the implications beyond not only low-grade glioma, but also beyond young oncology. Still based on the first question. What about the knowledge of the connectivity limitation according to the location of the lesion? Now, you are not Duffau. You are not this recruitment of low-grade glioma within the insula. This is beautiful, but in my life, maybe I will see once a year. That's it. Okay. Now you are on duty. It's 4 a.m. You have a patient with an hematoma in the left temporal lobe. The patient is aphasic. And the patient will start to worsen. You have to operate him to save his life because of compression. Okay. You meet the patient 3 months later. He's alive. You saved the life. You are very good. The patient is still aphasic. It's not my fault. The patient was aphasic before. And that's it. Are you sure? I will tell you that in 50% of cases, the patient was aphasic before because of the pressure on these pathways, according to the location. And then, if you decided to switch according to your knowledge in your mental imagery of the location of these fasciculi, without, of course, your navigation, awake surgery, and so on at 4 a.m., this is the real life. I'm speaking about the real life. Suddenly, you will give him, her, a chance to avoid to cut the ILF or the IFOF in my example, because he was aphasic 3 months later because of you, and you're not aware about that. And if you switch according to this knowledge, even at 4 a.m. with nothing, you will see your patient 3 months later, you know what? He will be alive and speaking.
That's incredible. That's incredible. So this is the beauty of how we are actually applying this knowledge basically, and it means so much. It's a way of thinking, and it's amazing, sir. And all these phenomena, it's so important, sir. Thank you very much, sir. Sir, but when we are actually talking about this glioblastoma, there is another thing that it is being presumed that the glioblastomas are actually using neuroplasticity to their own advantage, and those who are actually using the neuroplasticity, they are inducing neuroplasticity, are actually uh, promoting more aggressiveness. So is that the thing that you also believe in, that if the glioblastoma is there and it's causing neuroplasticity, it's basically using this neuroplasticity for its own advantage, and it is a more aggressive glioblastoma as compared to the others? What do you think about this new thing that's been all over in the literature?
It I published 20 years ago in Cancers, why gliomas are frequently located within the same areas, SMA, insulin, and my answer was interactions between the more active parts of the brain. So this is not new. This is just a nice illustration at the ultrastructural level of what we published 20 years ago. But on the other hand, what do you want to do? To stop plasticity in our brain and to become idiot? So we have to continue to push it. Then to remove, even if, of course, I have the habit also to say for 30 years, with no brain tumor. So we have to deal with that and to accept that nonetheless, it's better to increase the plasticity, to increase the quality of life, because what I showed in my results is that it's not against the optimization of the median survival. But of course, there is a fight between increasing brain processing to try to defend against this tumor, and the tumor, which needs absolutely to be in the brain because this tumor is unique and does not exist in other structures. So it's not new. Of course, this is once again common sense.
Yes, exactly. So that's the gain, and it was a, it was all a hype paper that was been published and been promoted so widely that this is what's happening, and it was something very, very, hyping up the whole internet and social media that this is a new thing that the glioblastoma is using this, all this all the phenomenon that I've been mentioned before. Sir, there is one question from Professor Gabriel Bergas-Garau. He has raised his hand. Would you like me to unmute him and invite him?
Please.
Professor Gabriel, would you kindly? Thank you. Hi,
Yeah,
sir.
thank
How are
you.
you? Nice to meet
Yes,
you.
how are you? Oh, nice to
Fine,
meet you
thank you.
too. Just to it's just a comment, Maria. Thank you very much for this excellent time, and to Professor Dufault. Just I want to thank you all your teachings, and I wrote that the most important way to apply your concepts to thank you is to try to really apply in our countries your philosophy and your way to do surgery. It's impossible to reach the bar that you put to us, but you need to follow you, and we need to really try to learn in each of your talks and try to apply the concept. So thank you very much again. Anytime that I can see your lectures, I learn a lot and try to apply. So I just want to thank you.
Thank you.
Thanks so much,
But I
sir.
totally agree. I mean, with the fact that it should be shared worldwide. Definitely, it's not constrained by methodological issues. So it just, as I said, in the end, your decision to implement new concepts, which are in fact old. You see, we are speaking about plasticity and gliomas. In fact, we developed the concept 20 years ago. I spoke about new fasciculus Arnold fasciculus. In fact, it was described 1 century ago. I spoke about awake surgery. In fact, it was developed 80 years ago by Penfield, and then later an epilepsy surgery, speaking about epilepsy by George Hirschman. So, in fact, we have the choice to refuse what was done before or just to be under the weight of dogmas. And I think that this is your responsibility everywhere in the world, not for me, but for your patients, for the future of our specialty, independently of money, politics, or method technological issues.
Political issues are very serious, sir. Political issues are extremely serious. I can tell you this is especially the story of countries which are still developing and still evolving in neurosurgery. So that's a huge issue, and that keeps the youth from coming in the upfront. And I think this is the youth which needs. I think we need to promote more youth, but it's very unfortunate. I can tell you that the youth is being a little bit pushed backwards, and this is a more political issue than a neurosurgical issue, and it's very unfortunate. And when I started my own initiative, sir, I can tell you I was totally passionate about it because I knew that I'm not the only one. I have a lot of people of my age who needs to learn and improve themselves and to push their boundaries, and they might not have this privilege of learning in their own countries. And it was a huge thing that was close to my heart, and it makes me feel a little more emotional still, because this is what I think, that we have this issue. And I'm really grateful to mentors like you who keep a lot of keen interest in training the young neurosurgeons and the young generation, and you show us the path to think the right way and to operate the right way. And I'm really grateful from the bottom of my heart for this huge privilege, sir. It means a lot. So there are a couple of questions in the chat box. Would you like me to share with you, sir?
Yes, please.
Sir, there is another question from Nicaragua. Yes, sir. He wants to ask: will your strategy change if the patient of low-grade glioma has presented with a larger neurological deficit as compared to the patient with minimal or no neurological deficit, but the tumors are located in the eloquent area. What will be the difference of your strategy?
Of course, in essence, awake surgery per se does not restore the brain function. So that means that it's just a tool opening the door to this kind of philosophy, but based on the fact that the goal is to not to restore brain function, but to preserve. So we can restore to some extent if the patient had seizures, as we say, and we can control seizures. We can decrease anti-epileptic drug, or if the patient had a slight but objective preoperative cognitive deficit, you can do postoperative rehabilitation and so on. But of course, if the patient is already aphasic or hemiplegic, because we arrived too late, so it will be a philosophical question, like in the example of the butterfly glioblastoma example I took. I mean, do you want to operate the patient or just biopsy with chemoradiotherapy, knowing that if the patient is still cognitively active, for instance, hemiplegic, and that's it, if I can say, speaking about cognition, you have to be honest with him and her, his family, by telling it's not because I will operate you that you will recover. It's not mass effect like the hematoma I spoke about at 4 a.m. or some glioblastoma with mass effect, and you do the lobectomy even under general anesthesia because you have not the choice, and then the patient will be better 3 days later thanks to decrease of the mass effect, the pressure in the head. In these examples, unfortunately, you have to be honest by telling, I can give you the opportunity if the tumor is not yet malignant to continue to control the disease, but you arrived, sorry, but too late. So I will not restore the function. So is it acceptable for you by, again, giving him, her, the à la carte concept, but of course being frustrated because the patient was referred to you too late. So once again, to prevent that, even in your country, I'm sure that it's possible to have this kind of webinar or what you want with neurologists, with younger people by telling, first of all, no, wait and see. If there is a brain tumor, because MRI and the patient is not perfect, but not so bad, you have to be referred directly to the Department of Neurosurgery, able to deal with these kind of patients, even if the bar maybe is not exactly the same, I said by Gabriel Vargas than in Montpellier, but I'm doing that all day long since 25 years. This is the reason why I'm here, in order to give you the opportunity to avoid waste time, but to find a good balance between okay, maybe we will not do incidental surgery, surgery for incidental low-grade glioma, but on the other hand, we can explain to all medical doctors in our country that if we start to have seizures or cognitive dysfunction, we have to do MRI and not to wait for the aphasia or hemiplegia before to decide to be managed in a tertiary center. So it's much more, to my opinion, a problem of education.
Yes. So right, so this is exactly what it is. And so you have also advocated screening for low-grade glioma, sir. So, but this is a too big step for many of us to take to screen the population, sir. So how do you think that it could be envisioned everywhere and widely? I guess that the only thing that we can say is that those patients who have a family history of some kind, so those can be asked for screening, because a wide application of the screening could be a little bit, a bit difficult and complicated for many of us. So how do you think that could be something of that could be done widely and to be accepted?
It's again, of course, the goal is not to ask to everyone, especially between 20 to 40, to benefit from brain MRI, because it will be complex everywhere, including in France. Finally, we have not so many possibilities to do MRIs. We have to be humble, even in France. But on the other hand, we have to open the door. It was our goal Like finally, when you have an history family of I don't know, lung cancers, and you are telling, I would like to benefit from a screening. And today, more or less everywhere in the world, we can understand that and accept. And sometimes it's in practice possible, sometimes it's not, but at least it's not something so new. So our goal was to say, why not in the brain? Knowing that finally what you need is only a flare sequence. So you don't need to inject, you do not need to spend 30 minutes in the machine to have DTI, fMRI, and so on, because the goal is just to say, this MRI is normal, yes, no. And to be honest, today, you will tell me at that time that you have no enough neuroradiologists, but we thought about that. Artificial intelligence can solve this problem, because I hate when we use artificial intelligence to make the decision for us, because it's not possible, it's not reasonable, it's not full of common sense. But to tell you, speaking about an imaging based on voxels and on numeric analysis, yes, this is in agreement with what we should have, or I have adopted, then we will have more or less 5% of the MRIs performed by those who would like to be screened, because an history in the family, as I said, but because also some vertigo, burnout, and finally connected to the web and by telling could be brain tumor. I'm not living with that. I need absolutely to have an MRI, and no one would like to do the MRI, and so on and so on. Finally, you will have more or less 5% of the MRIs considered by the software as non-normal, without telling you it's a low-grade glioma within the insula. And then finally, it's not so expensive, because we will have just to reinterpret this MRI, and not in isolation. This is the third point. I mean, when you do an MRI, you have a risk also, or a chance, to identify multiple sclerosis, other diseases. So it's not just low-grade glioma. So we have to make a link between different specialists interested by brain damages, especially neurologists. But it's logical too, because I'm not specialist of multiple sclerosis, but if we identified a multiple sclerosis earlier, many neurologists will treat earlier too today in the world, like us for neuro-oncology, like aneurysm to do clip or endovascular treating in rupture aneurysm. So everything is in the same direction. And if we start to think in network and not just the specialist of low-grade glioma would like to identify much more a tumor involving the insula, then it becomes ethically, politically, and speaking about money, feasible. It's exactly what we published 10 years ago in Cancer, speaking also practical and marketing issues, if I can say. And if it's true in France, I can tell you that it's true more or less everywhere, because we are not so rich.
That's a huge point, and there's a very it encompasses and it grabs so many issues in its own, and obviously it makes a lot of sense to proceed with it, especially with the age group that is being affected, and a lot of life expectancy of that age group that we can actually expect. And this age group is also important socially, and economically and everything. And I guess that with a lot of life expectation ahead of them, it could be the best way to think about the things at a very larger scale, and for the long term, in just to avoid a bigger issue, and just it's like a picking a stitch in time. So it's obviously something very important if advocated in that way. So there is another third point during the lecture. We talked about there could be a malignant a point in the center of the tumor. What about the volume? If there are multiple centers of that malignancy in the certain tumor, or if tumor is located at the resection margin. Sir, how would you proceed with that? If there's obviously the extent of resection is what really important in each and every case, but if the focus of malignancy if either there are multiple foci or if it is a larger one or it's located in the margins, how would you proceed with that case?
You're totally right. I mean, I spoke about the vast majority of cases in my examples with grade 3 or 4, just one focus, or 2 if you want, in the middle, but just in the middle. If you start to have many foci everywhere in the disease, then it's not really a low-grade glioma starting to be transformed focally. It's really high-grade glioma. And this is the point when I am against the classification of the WHO, because they do not take care of parameters we can see every day in the routine. I mean, the heterogeneity of this kind of tumor. And when I am discussing with the neuropathologist in Montpellier, and you can imagine with a lot of experience with so many patients, and when she starts to tell me, be careful because the tumor is becoming malignant, I will, of course, ask, is it really a grade 4 or just 3, if I can say? And second, everywhere or not. If she's telling me this is a diffuse high-grade glioma, I will say, of course, we need to do adjuvant treatment, even if I did at least a complete resection. Sometimes we can discuss about supratatorialization with 1 centimeter everywhere, but it's not so frequent. So yes, I will say we have to treat. But if there was even a focus of grade 4, not glioblastoma, grade 4 IDH mutated in the middle, and everywhere it was a grade 2, and I did a complete resection, and the growth rate was slow before to go to the war, then I will not suggest to do systematic chemo and or radiotherapy. And of course, we will have a collegial discussion with neuro-oncologists. The goal is not to take the decision in isolation when it's not a complete resection in a classical grade glioma. But not only in Montpellier, but now in many epicenters of this network in France, in Europe, and in the rest of the world, it's not so rare to have neuro-oncologists starting to say, oh, you did a very good resection. There was just a focus. And in fact, it's related to, I don't know, 4 mitosis in an astrocytoma. So that means that according to the new classification, it's grade 3. But in fact, 6 years ago, it was a low-grade glioma. Maybe we can wait. So you see also that we have to speak the same language when we manage a patient with this heterogeneous and diffuse tumor in order to think many times ahead and to explain to the patient that the price in this specific lower grade glioma to pay will be to have an MRI every 3 months. I mean, if I have a patient coming from some countries and I have a risk not to meet him before 1 year, never I will take the risk. I will say, finally, you have to be irradiated now because the benefit will be better. But if the patient is living in Paris and every 3 months he will have an MRI, you're sure about that, and he understood that if we started to see a regrowth just in 3 months, then he will have a chemoradiotherapy, no problem. So you see so many parameters finally, and not just like the rigid dogmatic classification for 3 mitosis, it's a low grade in astrocytoma, 4 mitosis is a high grade, low grade you remove completely, you have nothing to do because 1 more mitosis you have to do a Stub. No.
So this is very awkward because I can tell you that now that we have got this glioblastoma as a separate, with a separate definition or with the WHO, like the Hugo classification, and now that we have an IDS mutant grade 4 histiocytoma as what we can see at the parallel. So there's still a debate between giving the Stub regimen to the grade 4 histiocytoma, the IDS mutant grade 4 histiocytoma or not, because there are so many colleges that would recommend that, yeah, grade 4 astrocytoma, the IDS mutant grade 4 astrocytoma should undergo the stoop regimen, while the others debate, that this stoop regimen is what should be proceeded with for the grade 4 IDS mutant astrocytoma. And this is another point that's being, that I have seen in my local centers as well, that they think that, okay, if the patient is young, the section is good enough, the residue is very small, then okay, you can just uh, postpone the stoop regimen. It's not the exact thing that we are going to proceed with in case of IDS mutant grade 4 astrocytomas. And it's not like a frank glioblastoma, that is not an IDS wild type glioblastoma, that is according to the new WHO definitions. So this is what another point which is quite under debate, and people are actually having some sort of issues and concerns regarding this therapy. So this is something that is also of concern. Sounds alarming.
Definitely, the great interest of the last U classification was to make this difference between de novo glioblastoma, IDH mutated, wild type, I'm sorry, and definitely we have to consider that they are very aggressive and that we have to do two protocol and so on and so on. But you're right. Grade 4, what means today if it's IDH mutated? Because the meaning, first of all, is that it was a low-grade glioma initially, and we arrived earlier or later, I'm sorry, in the natural history of the disease. So it's totally different. It's another history than glioblastoma. And then I continue to think that we have to take care about multidimensional parameters variable. So we spoke about the extent of lesion, but also the delay between the first and second MRI and the growth rate, but also so the unifocality of this grade 4 or everywhere, we spoke about that before, but also the wishes of the patient. I mean, some patients would like to be more ambitious by telling if I do the radiotherapy now, it will not be possible later. Maybe I have cognitive disorders, not within the 2 years, but in 5 years. And if you did indeed a real maximalization for a real low-grade glioma, just with some foci of grade 4 in the middle, maybe we will use this ACE for nothing today. So according to that, you can decide also, first of all, to do MRIs, control MRI, not every 3 months, but every 4 to 6 weeks initially, just to see if something happened. More or less, this is the need 4 to 6 weeks to organize a radiotherapy everywhere in the world today. So if nothing happened in the meantime, and the patient is telling you, but I would like to give me a chance to think about the next feature, and because supratatorialization, and because slow growth rate before, because we didn't know, then why not? But also to incorporate multi-modality imaging. I mean, more and more we are using PET scan. And if there are some foci of hypermetabolism still visible in the residue of the tumor because you left 1 cc, okay, it was 90 before, so a very big tumor, so you are not surprised by the fact that you have some foci of malignant transformation because it was a big tumor. You left 1 cc because the anterior perforating substance for a paralimbic tumor, for instance. What you would like to know, in fact, is not if what you removed was so malignant or not, we answered this question, but what you left. And in essence, if you cannot examine this part, you will never know. So a solution could be to look at the metabolic issues non-invasively and to repeat PET scans every 6 weeks. And if you have no focus of metabolism, if nothing appears, and if the patient would like to give him or a chance, maybe not to use a treatment for nothing, then we can continue a regular surveillance initially and to postpone a little bit by an MRI with a spectroscopy MRI and so on every 3 months after that. If you have a focus of metabolism, hypermetabolism, it's better in your example to say, we have to consider it's a grade 4. I would recommend you to do a stoop.
That's incredible. So this is a very huge, huge thing that you have explained very nicely. So I think this will be a very useful precedent for everyone who is going to watch the recording as well, because you have done so, sir, so much elaborate discussion, and I think I have helped you for so long. But there's another question which is in the chat box, sir. Sir, I promise this is going to be the last one because I think I have helped you for so long. Sir, there is one last question. Is there a role of immunotherapy, especially in IDH mutant low-grade gliomas, and how many times you can operate for recurrence, meaning when to give up reoperating?
I don't know. Because speaking about low-grade glioma, the anti-IDH is still available now in France for 1 month, vorasidenib. Because in the New England Journal paper, they have more or less 2 years of follow-up. I have 20 years. I do not say that it's not a good treatment. I would like, as everyone, to think that it will be a very nice adjunct to the armamentarium. But who knows today? Because what they used, and I can understand that with so few follow-up, is they used a surrogate, namely the growth rate. And I'm not against the growth rate because we said for a long time we have to take care about the real volume of the tumor and to see if there is an increase or decrease and not to apply the Rano criteria plus 20-25%, which means absolutely nothing. But what I would like is to benefit from longer follow-up. So clearly what we are doing in Montpellier is if I did a surgery of low-grade glioma, so typically the New England Journal paper, we will not administrate systematically vorasidenib, anti-IDH, target treatment immediately. Because first of all, I know that I have a chance to reoperate a patient. Maybe we can give a temozolomide with a shrinkage, what we have seen. And I know that many people are telling that chemotherapy is dangerous. I'm not a chemotherapist. I can tell you that more than 20 years of follow-up is obtained not only thanks to surgery, but also thanks to chemotherapy, which was our first adjuvant option for more than 20 years. But in a patient, you did first surgery, a second surgery, finally chemotherapy, because you cannot reoperate because of diffusion within the connectivity, diffuse pattern you have understood. We have hundreds of patients like this. And now we don't know what we have to do. And we have the feeling that because it's difficult to demonstrate that it's a little bit too early to administrate radiotherapy because the quality of life of the patient is still perfect. But the tumor is recurrent. We have a perfect indication to use anti-IDH because it will not be against the other treatment. It will not be too late. I'm not speaking about low-grade glioma with already malignant transformation. We have understood that it will very likely not work or even have the adverse effect. But if it's still low-grade, you cannot reoperate before to irradiate. We have to discuss between chemotherapy and this new treatment. And if we are doing that with different philosophies, some of them will administrate earlier vorasidenib, some of them will administrate earlier chemotherapy, some of them will continue longer the follow-up after a good resection. We will have just to compare the real life about hundreds or even thousands of patients in 3, 4, 5 years, and we will have the good indications as not dogma because it was published in New England, but with more flexibility in order to adapt to a tailored based, personalized therapeutic strategy.
That's great. So thank you very, very much for this very elaborate account, sir. So there's also sir, more interest in the NICP, the neuro. This is again related to the to reoperations and to neuroplasticity induction. So there is also this, sir. One last question is that the NICP, the neurostimulation induced, cortical rehabilitation for the eloquent low-grade glioma, sir. So what do you think about that strategy to for those tumor in the low-grade glioma, the induction of neuroplasticity, the pre-rehab before surgery? How do you think that would be that's is it a good idea that you can think, especially if we are reoperating?
I started this part of my talk, just a few slides in the end, as you have seen, by telling this is a dream. It does not mean that it will not work. I would like to believe on the fact that it works because I know very well the plasticity in this context of glioma patients for 25 years. But I think that it will be dangerous to use too early this kind of tools without understanding the individual mechanisms. Once again, it's not just we will stimulate this area like it was a kind of localizationist view, but probably differently, different hubs of one network, and maybe by using excitatory or inhibitory stimulation framework, and maybe simultaneously, I don't know, in order to modulate networks. And how do you want to do it at the individual level if we have not yet understood how it was possible for the brain to reorganize when we made the diagnosis and after our first or second surgery? In other words, I think that we have really to be neuroscientists in order to start to play with this kind of tools, that we have first of all to understand the history of these interactions between brain network reconfiguration and evolution of a disease. And then it will be possible, explaining why I said it's a dream for me. I think it will be possible for you because to answer your question, yes, it makes sense. And I'm sure that in some patients it will be helpful. But today, to tell you, we have a protocol in order to make it feasible very easily, no. Once again, speaking about TDCS or RTMS, like for the surgery, like for the strategy, like for the decision of administrating adjuvant treatment, etc., etc. My protocol is that I have no protocol.
Sir, because you're the master, you can do it. And for us it's like we need to think see about so many things. You are the master, sir. You are such a gifted person, and we are lucky to have someone like you around in this field. And I think the patients are lucky to have a doctor like you, and all those patients who will follow in the future. I will believe that what you have done for all those patients and for all the research that you have done, it will be a very enlightening feature to bring more hope to such patients, and to bring more hope to in the field of neuro-oncology and neurosurgery, because it is something that whenever there's a patient with a glioma and a brain tumor, it's like a death sentence to tell to somebody, and it's like a very, very, sometimes takes a lot of toll and exhausting for the doctor, their him or herself, to tell that there's a grief that could be what could be followed to after that diagnosis. So again, thank you so much. I think we have held you for so long because we have got a lot of questions all the time, and we were so invested, so immersed with your talk, and I think we have brought up a lot of questions, and we have taken a lot of your time.
Thank you so much. I would like to conclude on the fact that really, first of all, I was happy to be with you because my goal is really to deliver this message, and not from myself, but from the brain itself. Second, that if I was able to achieve what you said, and to my opinion is more or less nothing, because I would like to cure my patient, is not yet possible, you will be able to go beyond. I'm sure about that. You have just to be connected to the brain. We have brain surgeons, and the vast majority of neurosurgeons I know are connected to the vessels, to the skull base, to the spine, and so on and so on. So why not? I'm not able to deal anymore with this kind of complex cases. But I think it's another philosophy. So be specialized as much as you can, as earlier as you can. Of course, after general formation training, I'm very happy to listen in some meetings that for younger people who were with me 20 years ago when I was in Paris, they remember that I was able to clip an aneurysm, and finally my patients were well. So it was very good for me, for my training, and for my patients. But to have these new ideas, you have really to focus. You cannot think that you will be very good and able to clip giant aneurysm with 99% of reliability, and just after that remove a brain tumor within so-called eloquent areas like Broca's area. It will be an illusion. So I think that you have to select, to choose, so to make a risk. Of course, I know you have not to lie to yourself. And I do not say that you have, like me, to spend 200% of your time just in the brain, but at least 50% of your time. And why not to mix also epilepsy surgery, non-lesional, or DBS, or now BCI? And once you start to understand the connectome, you can apply to many other implications I was not able to do in my life because I focus on gliomas. Fourth, that definitely you have to work a lot, but you don't need so many money, economical, political issues. We spoke about that, but I can tell you that it was not so easy for me 25 to 30 years ago to fight against the institution, but I'm still alive. So that means that my patients, the vast majority, are still alive, but me too. So if you are in the good direction, if you are honest with yourself, your patients, and others, if you are publishing regularly your prospective collection of data and multimodality, not only regarding the median survival for low grade, but also the surgical technique, but also the functional anatomy, but also because everything is connected. Yes, Duffau is doing so many things. No, everything is in fact integrated. Then you will see that you will succeed. I'm sure about that. And you have definitely to go beyond. And probably, my opinion, it's very subjective, the new field in neurosurgery for the next generation will be the functional restorative neurosurgery. We started to speak about that thanks to TMS, but one day I'm sure that it will be possible to give the opportunity to some aphasic, not when they have no brain anymore, but to speak again. It should be your ambitious goal. You are neurosurgeons. We are a little bit crazy to think that we can put our hands in the central nervous system of human beings. So please be really crazy by being really ambitious and by trying to change really our specialty in order to be more helpful for other patients, like after a stroke, for instance. Good luck.
Thank you so much, sir. It means a lot, sir. Thank you very, very much for all those talks and for all the information that you have shared and for all those encouraging words that have lifted so many of us so very well. And I think that I on the behalf of all the attendees who are present here and have attended the webinar, we will always follow your guidelines, your direction, and what you have shared. And like Professor Grau also mentioned, that this is the best way we can actually extend what we have learned from you. So again, sir, thank you so much. And it was a dream come true for me and for all of us to have this privilege of learning from you and listening to your talk. And after that, we had such a long Q&A and discussion session with you, and we took a lot of your time. And I'm really, we were so carried away with your presence that we could actually extend talking to you more and more. So we took, I think, 1.5 hour more for the talk. And thank you very much, sir, for spending your time. I know you have a very busy schedule. So again, I'm so much grateful. I'm so much deeply obliged with your kindness and your dedication and for your kind consideration. Thank you so much, sir.
Thank you, and congratulations for your initiative. Please continue to push younger people to meet older neurosurgeons in order to give them, I hope, this energy to go beyond. So please continue. You do a great job.
Thank you so much, sir. Thank you so much. It means so much to me. Thank you very, very much, sir.
Goodbye.
Bye. Thank you
Goodbye,
very
Gabriel.
much. Thank you.
My pleasure. Au revoir.
Au revoir, sir. I think all of you have attended, have received the quiz link. So kindly, thank you very, very much. Thank you so much. I've got so many wonderful messages in the chat box. Thank you very, very much. And um, thank you so much for joining in today, for the wonderful remarks and for your wonderful words and everything. And I think that all of you have received your quiz link and you have submitted the quiz link. I have also sent another one because there was one question that had no option. And actually, I've tried my best to make it a very something very easy and I know that the topic might have been a little bit of different from others, so I've tried my best to make it. It's also a non-grade quiz, so you don't have to worry about the grading then, etc. Again, thank you so much for the wonderful comments and. See you again so soon. And if you are on the WhatsApp group, please join the WhatsApp group to stay connected. And I will be, keep sharing more updates. And there is another, there is another webinar on 26th of April with Professor Prof.Hugues. So I hope to see you all there as well. So again, thank you so much. It was so wonderful to have you all around and to learn in a very wonderful way from such a big mentor. So again, thank you so much. I'm looking forward to your more support, and I guess we will keep on moving and learning more. So have a wonderful rest of the day and happy Ramadan to those who are celebrating. So I hope to see you all again soon. So have a good day. Bye bye.